Good evening, ladies and gentlemen, colleagues and friends. Thank you for joining us for another evening of our SPG webinar on the topic of treatment planning for the terminal dentition. Joining me on this panel tonight are my partners in crime. Starting from my left-hand side, we have Dr. Thao Truong, Dr. Agnes Lai,
Hello.
Dr. Zoe Potres,
Hello.
and Dr. Johnson Chou.
Hi.
Thank you guys. Thank you for coming, guys. I really appreciate your time towards this. And also, thank you for joining us this evening. As you know, that the whole purpose of this webinar is to share with you guys what we have learned over the years, and we deeply appreciate every single patient that you sent us to treat. We don't take that lightly. It's a privilege, and we shall do our very best to provide our services to you and your patients. This webinar this evening is, of course, live and interactive, which means that you get to send in your questions. And I'll do my very best to direct those questions at appropriate times to the panel to answer. And my apologies in advance if I'm not able to answer every single question, but I'll certainly choose the most relevant to tonight's topic. The webinar tonight will run for approximately, I think, 2.5 hours. If we're feeling very energetic, we may go to 3, we'll see. If you would like to have a CPD certificate, please do fill in your email in the section below. If you have missed our previous webinars, feel free to log on to our sypg.com.au website. On the top banner, there's a button for dentists with a drop-down menu with resources, and you'll find our previous webinars. Here's a QR code if you want to pause the screen or take a screenshot just to give you a sort of like a shortcut link to that if you like. Tonight's webinar, none of our presenters have any financial gains from our sponsors, which are only simply covering the IT cost of this webinar. And of course, please exercise discretion when using the information provided tonight for your patients, because every patient's case is unique and could be vastly different. Our sponsors this evening include Noble Biocare. So for anyone who's interested in an implant program, I'm the course coordinator, where it's a 1-year program separated into 4 modules covering from the very beginning of treatment planning to surgical placement, restorative, and finally some full arch concepts, including grafting and sinus lift. So a little bit of everything, especially if you're just starting off in your implant journey. I think this is an implant program option for you to consider. And once again, here's another QR code in case if you're interested. Noble Biocare also has a Asia Pacific Symposium coming up. It's one of their first times to hold their World Symposium in Asia, this time in Thailand. So if you want a tax-deductible trip to Thailand, this might not be a bad symposium to go to. Our second sponsor for this evening is by Dyneck. So for anyone who is interested in some handmade sutures, I think it's not a bad company at all, as I'd be thoroughly enjoying using their products. They have a full range of absorbable, non-absorbable, monofilament, multi-filament, basically a suture for every situation that you can think of. They certainly have it at a very competitive price. They're giving us some discounts. One is a 10% discount for any orders before the end of the year. And if you're a new customer, you get an additional 10%. So that's not bad. And if you're joining us for the first time this evening, just a little bit about ourselves, Sydney Prosthodontic Group. So we're a group of specialists, including prosthodontists and oral surgeon, Dr. Thao. As a collective, we provide a full range of prosthodontic restorative services, as well as many surgical services, including wisdom teeth extractions and tori reductions and all those wonderful things that Thao does. To cater for your new patients, which of course the waiting list always gets dragged on, we've expanded our premises in the same building on a different floor, just to give ourselves a little bit more operation room. So you may have noticed that your waiting list for your new patients have drastically reduced. So something they'll be working very hard on this year, and will continue to improve our services once again to you and your patients. And lastly, of course, on behalf of the entire team, once again, I just want to express our sincere appreciation of your trust in us to look after your patients. Because again, without your support, our services would simply cease to exist. So if there's anything we can do for your patient or for yourself, please feel free to reach out to us directly, whether by email. Many of you guys have my personal contacts directly. Feel free to ask any questions that you have, and if I don't have the answers, surely I can find someone who's a lot more intelligent than I am to give you an answer that I think should sound fairly legit. So without any further ado, let's dive into the topic this evening, which is treatment planning for the terminal dentition. Despite all the advances in dental prevention, technology, and predictability of our treatments, but from every now and then we still come across patients with the failing dentition. Now, the decision-making process to render someone edentulous is not always so straightforward, and achieving an outcome that is most predictable is not always that easy to achieve. So tonight's webinar is really designed to review the entire decision-making process, the treatment plans, the options, the treatment protocols for many different treatment modalities, and hopefully to improve the predictability of these treatment modalities. But like any other type of options or plans, I think we should always start off the potential option of no treatment or delayed treatment. Take this case here, for example. This is an 89-year-old lady who has been functioning on a lower removable partial denture retained by these two canines for more than 20 years without much problems. She's been quite happy with it, except in recent times the denture's feeling a little loose and there's been more food trapped under the denture. So she's very concerned that she might lose these canines soon and thus may significantly affect her quality of life. But upon assessment, I could see that there was practically nothing wrong with these canines. They are very robust, solid, and she's asymptomatic. So to improve her immediate denture function, we simply just provide her with some simple composites on those canines and a minor, localized reline of her denture. And she was very happy with the outcome. So perhaps for this 89-year-old who has been on Prolia for 8 years, she's diabetic with cardiac conditions and with otherwise a relatively stable dental condition and without much severe problems at all. Perhaps no treatment or the minimum treatment in this case might be more appropriate. You could argue that sure, we could remove the canines, maybe we could even place some implants to return her denture, but is that really necessary in this case? So often before making a decision for a patient or during that discussion, I think a number of options or a number of factors can be considered, which may or may not include the life expectancy of the patient. What are some medical factors or dental considerations, including how severe really is the dental problem? And is there any harm to the treatment harm to the patient if I provide a no treatment or minimum treatment? What about the finances or the psychosocial lifestyle impacts that these treatments may have on our patients? And I guess what I'm trying to say is that at the end of the day, what is the total risk versus benefit? The risk is a whole lot of risks. It include financial risk, biological risk, psychosocial risk, lifestyle, a whole bunch of stuff. What are they really getting out of this treatment at the end of the day versus how much benefit are they really getting out of it before we can really, I think, make a good decision on whether to proceed treatment or not. And if there's a situation where some teeth certainly requires to be need to be extracted or warranted to be extracted, could we save some teeth? Or it could be as many teeth as possible. It could be some strategic teeth for some very good reasons. Is that a possibility? Now, just because dental implant is a great therapy and there could be localized areas of failing dentition, but do we have to remove every single teeth? I think it's what we need to question ourselves and to bring that as a point of discussion for our patient. For example, this patient here, this is Miguel, and he's in his 60s when I first saw him. He's very much brachyfacial, as you can see, and he's really damaging his teeth quite badly. On this radiograph here, on a more closer examination, you can see that the teeth are breaking, his bridge is coming out, there's some failing teeth, there's some dental abscesses. In addition, he's got missing teeth, his occlusion is completely collapsed. There's some very severe attrition with this excessive deep bite and altered occlusal plane. So there's lots of problems here we could see. And that's why the patient himself said, look, Ben, I think I have really bad teeth. I've been having a lot of problems, and I really just think that I should consider having all my teeth extracted and have an all-on-4, because I heard a lot about it on different media, and that seems to be a very appealing idea, that from bad teeth to what seems to be good teeth in a very short period of time. What do you think? Now, when I assessed his teeth in detail, I could note that yes, while some teeth are certainly failing and needing to be extracted, but he still has quite a number of teeth that are of good prognosis. And I have absolutely no idea at all in terms of if I did extracted all his teeth and gave him a lot of implants, would that necessarily really work out better than keeping some of his teeth? I don't have the confidence to say that in a full clearance in this case is definitely going to be better. So but what I do know is that I know how to assess teeth, at least the teeth with a reasonable prognosis. Now, if I could save those teeth, providing him with good restorations, I know that he has a very good chance of lasting for at least 10 plus years. So I spoke to him in detail with a lot of different options, and we defined our objectives clearly. And so we started on this journey of first we got to remove, of course, the teeth that we can't save. And then on a wax up, I could increase the OVD, and then using this model, I could simulate what roughly his new OVD may look like. And I quickly transfer that information into his mouth at the increased OVD so that I could now provide him with a very average looking removable partial denture. So now at least we got ourselves a little bit more restorative space, a better occlusal plane to deal with, and a slightly more stable condition. And from there on, we could sit on it for a little while. We could test these teeth, whether they work or not. And if it's proven that this concept or this idea might work, we could now start to place some implants in segments. And this case was done more than 10 years ago. So while we're waiting for the implants to osseointegrate, I could now start placing some strategic crowns. And once the implants osseointegrated, we could then just, it's very simple to provide the patient with just short segments of fixed implant prosthesis. So in total, we've replaced some missing teeth to encourage posterior mastication. We've improved the occlusal plane and the occlusion, improved the aesthetic outcome, and of course I'll be absolutely mad if I wasn't controlling his parafunction. And the beauty of taking some time and treating his cases is that I could test his compliance and who he really was, and to make sure that he is someone who can keep his teeth in the years to come. So now that this case has been going on for longer than 15 years, I'm glad to report that his teeth are still there. His implant prosthesis is chipping and is breaking, as we do see in these. Particularly, this is a porcelain fused gold prosthesis, and that's largely because of the loss of proprioception. Now we know that teeth and implants could be quite different in the sense that teeth have proprioception, where implants has what we call osseoperception, which means that implants have 10 times less sensation when compared to teeth. So if you were to render someone completely edentulous, well, now they have significantly less proprioception, and therefore they're much more likely to break things because there's lack of control of the muscles, etc. So ultimately what I'm coming down to is perhaps consider, what are the strategic teeth you could save? If you can't save one arch of teeth, could you save maybe the opposing arch of teeth? That will give you some proprioception. If you're struggling to do that, maybe even just an opposing pair of posterior teeth. That's better than nothing. Right? So some proprioception is better than no proprioception. So hence, I guess in summary, what I'm trying to get at here is that while perhaps our full mouth implant or not based rehabilitation might be predictable in some cases, but it's certainly, we don't mean that every single case needs a full clearance, because some cases may not need any treatment at all, while others we can certainly save a lot of good teeth. On the topic, continue on of assessing this patient, medically speaking, that's another huge factor that we need to open up. Thao, do you mind share with us some of the medical factors or conditions that sometimes may lead to the terminal dentition, and sometimes we have to take into consideration of when we're managing the patient, especially surgically, what are these medical conditions that we should be looking out for?
Yeah, sure. So I think it's really important that we realize that, we're dentists, and sometimes we just look at the patient's teeth, and it's really a person attached to those teeth. And so there are a lot of conditions we need to think about. And we're really going back almost to dental school, where we talk about medical history. And a lot of times we go, oh gosh, this is quite boring. Of course we take a medical history. But it's important, if we're doing quite extensive work on a patient, that we really hone in on what medications they're taking, and how that's going to affect them in the long term as well. So I'm sure you all know how to take a medical history, but a lot of the times the patients tend to omit a lot of their conditions, because, for example, a patient, you can ask if they have hypertension, but they might say no, and that's because they're now on medication to control the hypertension. So to them, they don't have a hypertension. And a lot of medications, like, for example, Ozempic, Wegovy at the moment, a lot of patients don't think it's necessary for the dentist to know. But that does also affect sedation, for example. So it's really important that when you ask the patient their medical history, you look at specifics, like currently what medications are you on, and are you and when they give you particular medications, you kind of hone in on why they're taking that. So from there, you can look into what complications could occur during the surgery, and how can we make anything, as all the treatments we give the patients, as safe as possible. So the question is really, how can we safely treat this patient? So there's lots of different ways that we can assess how fit our patient is for treatment and surgery. So one that a lot of people know of is the American Society of Anesthesiologists, the ASA classification, which divides it into, your class 1, 2, 3. And in the majority of the cases, you find the patients in the class ASA 1 and 2, and sometimes 3, you can safely manage. But anyone's heading towards, I hope we're not doing it on a patient that's, 6. But another way to assess it is really looking at how they can walk upstairs, for example. If someone's fit and healthy and they can walk up a flight of stairs, that in general their surgery they're gonna recover well for surgery. But if there's any type of difficulties going up a few flights of stairs, or they can't even make their own way up, you need to think, are these people, how are they going to recover from their treatment and their surgery, and whether you need to stage it, or whether that treatment would be appropriate for them. So you need to consider the procedure you're planning for the patient, the complexity, the associated morbidity, the length of the procedure as well. Is it better to space it out, or is it better to have one large procedure? The skill of the surgeon involved and the anaesthetist is really important. And what we often forget is the support of the patient, perioperatively and post-operatively. So it makes me wonder how much of the outcome that we can actually control. And to make things more predictable, I always try to think of all these factors that come into play and really explain to the patient. Because a lot of times the patients they just think of it, the outcome as based on your skill. They don't think of it's because of my overall health. So I tend to bring that back on the patient as well. It's kind of like a cooperation between your skills, the patient's ability to heal, and the patient's compliance. And when you bring things towards that element, patients are more understanding when their recovery takes a little bit longer, or there are delayed healing or infections involved. At least we kind of know this is what we expect, and we can move forward from that, and there's no loss of trust in the skill, your skills. So with medical status, I think everyone's very much well aware that there are particular conditions that makes, which would mean that the healing of the patient or the appropriateness of treatment would need to be considered. So when I talk about uncontrolled diabetes, I'm not talking about high blood sugar level at that one point, because they could have had just like a high sugar meal before they turned up. We're talking about the HbA1c, so their blood sugar control over the 3 months. And then patients who have a history of chemotherapy, radiotherapy, long-term corticosteroids, drug use, and anti-resorptives, anti-angiogenics. All these are involved with overall healing of the patient. So when there's reduced healing potential, you have an immune compromised state, you need to think, how is that going to affect the patient's recovery? And with recreational drug use, you need to think about compliance, which comes to an example that, Ben, you had this example for your case.
Yeah, this was a relatively young lady. She was only in her early 40s, if I remember correctly. She was a primary school teacher. She had 6 anterior missing teeth from canine to canine. And she just wanted she's been having this partial denture, and she wanted to have a fixed implant bridge. So it was from that treatment point of view, it wasn't that complicated. I did needed to place 3 implants with some minor bone grafting. So everything went well, went uneventful, except 3 days later I received a phone call from the local hospital's registrar, who says, I've got one of your patients here. Rocked up in emergency. She's in a tremendous amount of pain, and this is during a weekday. And I was scratching my head and saying, why did she not come back to us? Well, what have I done wrong? And he quickly explained that she's very embarrassed, the fact that because she's been on cocaine, she's been admitted multiple times in hospital before, and she's just too embarrassed to tell you about it. That's why she's here. She wants us to manage it. She's hoping this problem can go away, and then by the time she come back to you, everything is sorted. But this is that's not healing. So every time when I would primary closure, lots of sutures, within 2-3 days, everything would just open up apart. And so I would just have to repeat this over the course of about 2 weeks. On pretty much on a 3-day basis, until we get some sort of primary closure. I knew those implants were gone, but she wanted me to keep them there for long, just for hoping for a miracle to happen. And of course, 3 or 4 months down the track, that's where we're at. All implants have to come out, and she's back on her partial denture. It's a very sad story.
Yeah.
I wish she told me something about it. We have those questions on the form, and I let my guard down, thinking that she's looking fit and healthy. Surely, that should be one of the last questions I should ask. I didn't. I got caught out, and that's where we're at.
Yeah. I think that frank conversation about recreational drug use is so important, because the patients tend to go no. But establishing that rapport early on in the consultation allows them to open up, because you can mention that this is what affects your outcome. So it's really important. So Thank you for that example, Ben. So for the next one, this is quite an extensive list of anticoagulants, but this is just a reminder that when patients are on medications, and this is an example of multiple medications, anticoagulants that patients could be taking, and the reason I put this up is because all of them have different mechanisms of actions, and it's important for you to firstly ask the patient why they're on the anticoagulants, and also liaise with their medical practitioner as well if you're planning to stop anything, because as you can see, for example, clopidogrel, the time frame for it to really to stop before surgery requires 5 to 7 days. And how many times has a patient turned up and go, "Oh, I've stopped my Plavix yesterday"? And that's really a misunderstanding of the mechanism of action. And the patient's not expected to know that, but it's important for you to pick up on that early on. And so again, this is something that you can take a photo of, but it's really to understand that every patient is different, and I don't tend to stop their medications for any treatment unless it's under the appropriate advice of their medical practitioner, and there are local measures that can be taken to control bleeding. And this is a reminder with smoking. We all know smoking is bad, but just a reminder that the smokers are more likely to get dry socket, they're more likely to have implant failures, and there's a lot of issues with delayed healing with smoking as well. So again, I focus on the pack years as well as the active smoking. A lot of patients also tend to think I've stopped smoking for the last couple of days for the surgery, which is, we know, is not the same. So it's important that I'm realistic. A patient who's smoked for years is not suddenly going to give up for the surgery, but it's important for them to understand how it affects the outcome of their treatment, and then also use that time to really focus on helping them, add on to reminding them that this is a good time to give up smoking as well. And this is an example. I think this is your example, Ben.
This is another relatively healthy patient. Again, the treatment is relatively straightforward, but he's a smoker. So I placed the implants. Again, this is a very old case, and it's completely buried, thinking that I've controlled all the risk factors, and then he goes back onto smoking.
Of course.
And then by the time he comes back, in 3 months' time, all the cover screws will be exposed, and as soon as you see that, you go, that's not good.
Yeah.
And of course, on the next slide, we could see that there's thread exposure.
Yeah.
If you don't mind.
Yes.
Okay.
Yes.
Yeah.
Of course.
So now we have bone loss down to the first, second thread. It's not great. He was happy to proceed, but this is far not the ideal outcome that we want to achieve. Here's a question from the panel for you, Thao, that if you have a heavy smoker with active perio and says, I want implants, what would you say to them?
I'll be like, no, control. I think it's important that you have that conversation with that patient. Obviously, but if you think about the timeline that they've come in, when you talk about heavy smoker, has anyone spoken to them about giving up smoking? Have they seen a periodontist? So there's a lot of factors, not just that one time the patient walks in. But if a patient who I've never met has never controlled their perio, poorly compliant, then implants is a no-go, essentially. So essentially no discussion is complete without mentioning MRONJ, and essentially, which is medication-related osteonecrosis of the jaw. I can spend hours talking about this, but with obviously the time limitation, I'll really speed through it, because the reason why we're talking about it is every second patient over 60 now, especially females, are on some sort of anti-resorptive, and I find that more recently I'm being referred either young patients with wisdom teeth or older patients who are on Prolia. Those are my two main, so it's just a reminder of what's currently in the literature, and so I will speed through this, but obviously there is a lot more to it. I don't want to undermine how important it is, but you're talking about bone exposure of more than 8 weeks, arbitrary number of 8 weeks, because if it's 7.5 weeks, this is still MRONJ. The history of anti-resorptive therapy, and the history, and no history of radiation therapy or metastatic disease, because if it's radiation, you're talking about osteonecrosis of the jaw. Now, anti-resorptive therapy is important, and there's a lot of patients now who are suddenly scared to go on Prolia because they think there's this idea that it's going to break down their teeth. So sometimes I spend half an hour just talking to the patients about, don't stop your Prolia. Prolia is important for, you know, osteoporosis related fractures, hypercalcemia of malignancy. So it has its role. So it shouldn't, the patient shouldn't be you know, stopping it or not taking it. The main thing is that they're appropriately advised and that they see a dentist regularly, and any teeth that require removal will be done early on. This is opposed to bisphosphonates, which I find is slowly being kind of phased out. I'm not seeing Fosamax much anymore, but I am still seeing a lot of patients on the IV bisphosphonates for, you know, cancer treatment as well. So they actually bind to bone, and I'll talk about risk factors later. And again, I mentioned denosumab, which is different in that it's a monoclonal antibody, so it inhibits osteoclast function. It's 6 monthly, but you find that after 5 months, the majority of its effects have worn away, which is why we take it 6 monthly, which comes down to when it's appropriate to take out the teeth. And this is just a reminder of the difference between your bisphosphonates and your rank ligand inhibitors, which is your Prolia. And just a reminder for everyone that there is no, at the moment, there's an indication for no drug holiday. Previously, we talked about maybe putting patients on drug holidays, but there is an increase in rebound fractures following discontinuation of Prolia. So the idea is we want to time the treatment at least for me, at least a month before the next Prolia, because relatively we find that there's no safe time, but we know that biologically that's the time when most of the antibody is out of their system. And a reminder that this list keeps getting bigger and bigger, but there are other medications now that are associated with MRONJ, and the reason that they're only in case studies is because not many patients are on it, but it's a reminder that there's a lot of you know, your anti-angiogenics, your chemotherapeutics, and immune modulators, and the list keeps growing. So I would, if you don't know what medications you're taking, look it up, and I can assure you if there's some sort of immune modulator, it's associated with MRONJ. And this is just showing that, you know, anti-angiogenic drugs are, you know, essentially they also affect bone remodeling because they're affecting blood supply. So if you affect the blood supply to the mucosa, you're affecting blood supply to the bone as well. So this is a good picture just to show that the pathophysiology of MRONJ is multifactorial. So you're looking at, you know, anti-resorptive medication, but that's not only it. You have to have some sort of inflammation, infection, inhibition of angiogenesis, soft tissue toxicity, or some sort of dysfunction in the immune system. So I like to put it in my own kind of category here, which is some sort of disruption of the mucosa, some sort of disruption of the blood supply and cellular turnover, and some sort of delayed healing. So whether it's all of this or one of these or two of these, there is some sort of disruption of the normal processes required for normal bone healing and mucosal healing. So then you get osteonecrosis. Whether that happens with or without exposure or with or without infection, really it means that to get to a resolution, it needs to be very specific to the patient. So I'll be very quick. So we know what the risk, I won't go into too much, but the risk is actually very low. The highest risk is IV bisphosphonates, and when they're on medications for greater than 3 years, the accumulation. Also, if it's on Prolia, you have to think about the history of bisphosphonates on top of Prolia. And also if they're on systemic corticosteroids on top of that, okay? And there are lots of studies out there trying to risk stratify, deciding whether they're high risk or low risk, and again, it's based on length of treatment, the type of bisphosphonate or the anti-resorptive treatment, and also other risk factors that affect healing. And this is a reminder that there's several stages of MRONJ. So you get from just symptoms alone, or some sort of bone exposure without infection, and then bone exposure with infection, and then the extension of that bone exposure. Prevention for everyone should be this is very well known, you know, patient education, and that's so important. Good hygiene. You focus on prophylaxis, you know, controlling the disease, making sure that the denture is well fitting, and maximizing the patient's overall health. Okay. For me, the idea is you want to have any treatment before the anti-resorptive therapy, okay? Endodontic treatment is so important in this case. There is a lot of discussion whether antibiotics is appropriate. For me, part of the reason for the etiology for MRONJ is bacterial. So important to have a pre-operative dose and based on the patient post-operative as required. Antimicrobial mouthwashes, primary closure if you can. There's a lot of studies now on pentoxifylline, in Australia we call it Trentol, which has been used for prevention and management that has worked well. And I'll show you a case quickly. But the idea is if a patient has malignant disease, you need to think about the patient overall, and you really want to avoid surgery as much as possible, and then dental implants are very much contraindicated. So I'm just going to show you an interesting case. This patient of mine was 75 years old, on Proly for 7 years. You can see that the 3-7 has fracture filling, has a draining sinus, and it needs to come out. There's no way we go about it. So I followed my protocol, which is A-B cover, scheduled the extraction 1 month before the Prolia, chlorhexidine mouthwash. I did a sectional removal of the tooth, smoothed off all the sharp bone, and primary closure. So I reviewed her at 2 weeks after extraction, and then 2 weeks after her Prolia, and then 8 weeks, 6 months, and 12 months. So everything was healing perfectly well. So I controlled what I needed to do for the surgery. However, her denture didn't fit well. And so she ended up getting MRONJ on the lingual aspect from a poorly fitting denture. So you can see on my end, we can do whatever possible, but we forget that there are other etiologies involved with MRONJ as well. So this is just conservative management. She's got other medical issues going on at the moment, so it's just monitoring at this stage for her. And she's not in pain. It's just making sure that we don't progress to anything beyond a stage 1 at this stage. And just a reminder, there's conflicting data in literature about implants and MRONJ, but if the patient is high MRONJ risk, then don't put an implant in, really. But very few patients are super high MRONJ risk, so just be mindful and just explain to patients the risks associated as you would with extractions. And most implant failures occur later on. And it's important to understand that it's not, we often think about implants at the time of surgery. We forget that when we put the implant in, it's going to be there for however long. And the patient may have MRONJ associated with the implant in the years to come as well. And summary, so this is just a summary of the implant aspect again. So I'm going through it very quickly, but and in terms of management, I'm just going to go through some of the quick managements of some of the cases I have myself. Okay, some of them my self-resolve. Okay, so we have a case here of spontaneous MRONJ on the lingual aspect of the 3-7 site. And with this case, it was just chlorhexidine mouthwash. And I actually put this patient on pentoxifylline as well. And then just monitoring, no surgical management, and you get resolution over time, okay? And that was just monitoring the patient, and they were compliant as well. And we still don't know how that MRONJ occurred, probably trauma. In this case, this is a case where it shows a later progression of MRONJ. So this patient had a full clearance done in general practice 9 months earlier, no issues. She had a denture made, but slowly the denture became mobile because she had buccal and lingual swelling. And then you can, and she had been on Prolia for 5 years and almost 10 years of Fosamax. And if you look at the OPG, you can kind of see something happening anteriorly, and then when you take the CBCT, you can see that large sequestrum. So in this case, the management was really just to remove the sequestrum, okay, because it's dead bone. Quite simple. This is under LA, and I removed the sequestrum, and you can see that large piece of sequestrum, and I curated the area and achieved primary closure, and she was fine after it, and the healing was fine. The denture, she just needed a reline of her denture. And finally, this is an example of, this is actually stage 3 MRONJ, sorry. So this is one of the few cases of stage 3 MRONJ you see. And when I say stage 3, it's because it's infected, there's exposed bone, it involves the maxillary sinus as well. So this treatment becomes more complex for this patient here. So I just wanted to quickly go through my thought process of how I treat these patients. So for me, when I plan any treatment, I think about the negative factors that are involved. So the patient had been on greater than 5 years of Prolia and they had their recent injection, so high dose of antibodies in their body, history of smoking, the existing exposed bone, and a thin biotype, as you saw. What are the unpredictable factors? Well, if we're doing an OAC or antral communication closure, I don't know what the quantity of fat pad is going to be, especially with a history of smoking on an older patient. I don't know the quantity of necrotic bone that's happening underneath. It's actually very hard to know. We previously were taught if the bone bleeds, that's where, but you can keep drilling and the bone may not bleed. Intrinsic healing factors, the patient's own blood supply, cellular healing. And then the reason I mentioned the distal involvement of the 2-6 is because to get OAC closure, you need to be surrounded by sound bone. And if the root of the 2-6 was involved, that won't work out. So there are things that I can control. So antibiotic coverage, chlorhexidine mouthwash, Otriven nasal spray to maintain the ostium patency, and a double layer technique of fat pad and buccal advancement. So if you look at the surgery, you can see where the oral antral communication is. I removed a lot of that necrotic bone and I retrieved the buccal fat pad. And then you can see I've closed a buccal fat pad over the communication and achieved primary closure. A lot of people used to ask me, why do you need the buccal fat pad? Why can't you just do a buccal advancement? Well, when you get swelling, there will be dehiscence of the mucosa. And here, this is what happened. But what we have there is the buccal fat pad, which is giving it the blood supply it needs for healing. And with that, I just monitored. And then over the next couple of weeks, it's completely healed over. Okay, so the patient now has no more symptoms and complete closure of the oral antral communication.
Thank you so much, Thao.
No worries.
I think that was the fastest management of MRONJ
I tried.
in the history of MRONJ.
I know.
Well done. 20 minutes of management of MRONJ. Two very quick questions.
Yes.
We just about get these questions every single time.
Mm-hmm.
Prolia, patients that's on Prolia, is that a contraindication for implant placement? You covered it, but I think just wanted to clarify that one more time.
Yeah, I think it's important to understand that, look, the Prolia is accumulation. So you think about Prolia, they're going to be on Prolia for a long time. Very few patients come off it. So if you think about implant therapy, it's not just about the placement at the time. It's about managing the patient over the long term. And so you can get osseointegration, you get perfect implant placement. But then if the patient's oral hygiene goes down, because they're getting older, their dexterity changes, their ability to take care of themselves changes. So who's going to look after them when they have MRONJ associated with Prolia? Different if they were 40 and 50, some people are on Prolia early, as opposed to someone who's 80 or 90 as well. So it's not just the Prolia, it's the overall patient and what you plan for them, and also think about the long term, okay? Because function is important. A person in their 40s and 50s, they deserve good function.
Absolutely.
But at the understanding of the importance of follow-up as well.
For sure. And CTX always comes up.
So CTX, yes.
Serum CTS test. How predictable is that? Do you use it? What's the controversy there?
The only controversy is the fact that it's unreliable. The current consensus statement by the American Association of OMFS surgeons say that it's not reliable enough. The actual testing does not mean that you're going to have less MRONJ or more MRONJ at all. But some people still use it because they find it's a good marker for that turnover. And so for me, it's just patient education. One thing is not going to stop the MRONJ over another, okay? But for your peace of mind, for your understanding of your patient, it may be worthwhile, but just understand the testing can be quite expensive for the patients. Yes. And also the allocation of time, etc. So if you're finding it not useful, why are we doing it? And also if the CTX shows that it's all good, but then the patient still has MRONJ, how is that going to protect you?
Yes, it's a false positive essentially. Right?
Exactly. Yeah.
If I understand it correctly, stage 0 MRONJ, it's MRONJ, but it's asymptomatic?
No. So we've CBCT scanning has recently shown that some patients they present with unknown pain, okay? And in their mouth, there's no exposed bone, and they can't see what's going on. But what we've found is when we've taken a CBCT, you can actually see sequestrum forming, but underneath the bone. So when we talk about stage 0, it's those patients that have unknown pain, but they can still get necrosis underneath.
Right.
It's just the mucosa is still together.
Terrific.
Okay,
Thank you.
so that stage 0 is just that weird, I don't know, they're on prolate, they're getting pain, but I can't really see anything on my 2D imaging. Take a 3D image, and then often you can actually see the sequestrum.
Fantastic.
Yeah.
Thank you so much. Continue on of assessment of our patient. Now that we've covered the medical aspects, now, but from the psychosocial or the frailty point of view, that's also an aspect that's very rarely talked upon. Not every patient with a terminal dentition is necessarily frail, but often there is a relationship there. Agnes, do you mind share with us some of your wisdom on this topic?
Thank you, Ben. So as we are talking about managing terminal dentition, I think before we argue over what is exactly, how do you define or what marks terminal dentition as deeming them needing removal, as the seminar tonight continue, we will be touching base on that. But on the notion of respecting that we are about to take our patient through the process of tooth loss and then receiving some form of tooth replacement, no matter the type of prosthesis. So while we are talking very heavily on implants, implant retain, implant supported, implant as a modality, we are covering all different types of options tonight. And thank you, Thao, for discussing a lot of the surgical and the management aspect. But let's collectively have a think about treatment planning more from an oral rehabilitation point of view, because we do need to consider our patients' learning capability and their adaptive potential as we are talking about losing a body part and we are replacing it with some form. So we can broadly look into 2 dimensions when we are looking at these aspects. One is their personality traits, with their mental readiness to embark on this journey. And the other aspect is their physical capability. Not so much just for the fitness of surgery or getting into the chair for the procedure, but their physical well-being as a whole. So if we have a look at this slide, the personality traits that not unfamiliar to us, that we know are helpful for us to learn new things and to adapt are openness, conscientious. So openness means they're creative and they're open to new ideas. Conscientious means they are commonly quite proactive and they can structure themselves. Extroversion helps because it means that they're connected with people, they like to have a conversation, they're probably more receptive to receiving advice. It doesn't mean you can't learn things at all if you are more on the introversion side, but usually that is through more they recharge in their solitude, so they have to be more self-directed. So you can provide them with the information, but in terms of the communication platform and assisting in their rehabilitation, the communication tool might be a little bit different. That sense of agreeableness, of course, whether they are in that cooperative stage. So these 4 dimensions of the personality traits, if they are high, they are in your favor. These people usually have a growth mindset. You can discuss their problem together. They're probably quite proactive of suggesting what might work for themselves, and they are also resilient. One of the dimensions that is also one of the major 5 personality traits is neuroticism. Usually people with a high neuroticism state, though, they are a little bit more emotionally unstable. So these are not clinical diagnosis. These are just traits that we are talking about, okay? So what you may find, people who have high neuroticism, they can be more prone to presentation of stress, anxiety. These traits does make people have the characteristic of being impatient, quick to get angry at things, a bit more pessimistic, easy to become irritable or frustrated, and quite sensitive. And I guess as we talk about these traits, it reminds me of dealing with children a lot. But it is not dissimilar, because this is about learning capability, which is fundamental when we are taking people through the process of rehabilitation. And don't forget, on top of that and before that, we are dealing with tooth loss. Now, poor oral health and tooth loss are associated with higher state of neuroticism, knowingly, because, people have been putting out with lower self-esteem, lower self-confidence. Although, of course, you can have some patient who just detest their own teeth and can't wait to just get rid of them and have new ones, and they feel very motivated. But I think as clinician, and with the heavy promotion at the moment about dentists being a health provider versus dentists doing elective cosmetic delivery of work, it's so important, just so similar to those who may present with a lot of veneers or in cosmetic work in demand. It is not uncommon. We all know that we have to try and screen whether there is any other underlying mental health presentation, such as body dysmorphic syndrome. And similarly, it is so important that we do need to identify patients who present with terminal dentition. So especially if they are younger in their presentation, and to a certain degree, it may have involved a certain aspect of neglected mouth to become the state that they are in, that we have to distinguish whether we are restoring the health of the patient, and in so doing, we are improving their smile, we are improving a healthier look and function, versus the patient's primary incentive is to, get rid of my teeth, I want particular, so they will be quite dictative on, I want implants. For example, maybe like the previous question, heavy smoker, active periods, dating, I want implants. There are just different layers of patient education you probably have to comb through before deciding, how to best help that patient. Otherwise, you could be ending up with more risk and complication than, and it's just a very dissatisfied patient, even after delivering a clinically apt result, but they may not find it easy to adapt. And if they are OCD, they could be very, very upset by the fixed prosthesis in their mouth, that every time they pronounce certain thing, they just don't sound the same as they want to, no matter how hard they have tried. So sometimes these complaints can have a very genuine basis, but at the same time, if the tooth loss process was not really indicative but one of election, then there could be a lot of gaps to break. So aside from that mental readiness aspect, let's have a talk about our aging population. I know and I do respect that there are younger cohort who are faced with what we call terminal dentition, including those who present with a lot of work that are required in their teeth. And they are perhaps in their 50s. And sometimes you are battling, even as a clinician, that the cost for them to manage their dentition to health is more costly than removing them all to just give them full arch implants. So here, as we stand to talk about this topic, I think before we tackle this very important question, let's have a look at our population. So in Australia, currently, we have about 19% of our adult population, of the whole of our population being above 65 years old. And we are on that trajectory to hit 25, like a quarter of our population will be over 65 by the time it's 2050. So it's a very significant cohort. But if we were to look at the dental awareness of our patient, 1 in 3 adults above 18 walking around will have untreated caries in their mouth. And the statistic, according to 2017, 2018, so this is a little bit pre-COVID. I think after COVID, it probably might be even worse, but we don't know until newer data comes out. But 1 in 2 adults have seen a dentist in the past 12 months. So seeing a dentist in the past 12 months doesn't necessarily mean regular care either. It could be that they're presented with a dental pain or problem. So what this essentially tells us is that we have quite a poor dentally aware community or older cohort. Our older cohort also culturally in Australia like to be more independent. So 95% of people above 65 lives independently, and only about 5% are in aged care facility. And of those in aged care facility, the average age is around 85 years old or above. So it's quite high, so the people are living quite long. In those who are living and walking around to the community and those who are quite likely to present to your clinic, you must actually understand that nearly 90% of them are living with some kind of long-term health considerations. And more than 50% of them have some form of disability, whether it's mobility or whether it's impaired hearing or some kind of visual aspect to themselves that they report their need of disability aid or aid at home while they're living at home. So, and there are actually quite a number of dementia patients above age 65, about 12%, and only 5% are in the aged care. So there could be a good number of them walking around that they may seem very cognizant as you're talking to them, and that they could walk out and maybe they had forgotten half of what's being explained to them. And finally, I think Thao has covered is there's a significant amount of people on anti-resorptive drug that may not naturally or easily know to volunteer those information. So really, in summary, people are living longer. So of course, they do want to be involved with planning the quality of life as they age into this bracket. But we must acknowledge that there is quite a low dental awareness amongst. So as part of that treatment planning process, patient education cannot be missed. And often I would say, rather than just enlisting the risk that they have with them and what are the risks that, depending on the treatment choice, that they still bear. Because no matter which treatment choice they choose, there will still be the maintenance and servicing. An implant does not necessarily make that maintenance journey easier or more affordable. So, and the complex care before you proceed is that you do need to be aware that if you have a patient in their 50s and let's say we have very high confidence level in your reconstruction and you give them excellent, course of rehabilitation, that they enjoy 20s, and I think, even beyond 15, 20, 25, it's an excellent time frame. But whether they become frail or not, it is very likely that throughout that journey, there will be still recall and maintenance and their own responsibility in looking after their care. But it is quite likely that they may need some other form of rehabilitation that suits their needs at that particular time in that next phase of life. So how do we match this up? I think, it's not to deviate from our normal treatment planning so much, but as I highlighted, is to ensure that we communicate that risk factor into a problem list that we are working with. But how does that fit into translating these to access and functional capacity of that patient? What are the exact, responsibility be like? What is that maintenance schedule? I think a common term we hear in our periodontal colleagues a lot, supportive periodontal therapy. We all can accept that 3 monthly we see them. There is an emerging concept of having supportive prosthodontic therapy equally for, in particularly those who do have additional risk factors behind them, whether these be dry mouth, parafunctions, and each of the prosthodontic modality may dictate their own maintenance need. So recognizing that as people age, usually in a healthy cohort, above the age 80 to 85 is when we begin to see any signs of motor degeneration or sensory degeneration. But in patients who present with other chronic diseases, some of these deterioration we can already see around that age 65 to 70-year-old. So the Canadian faculty have devised the clinical frailty score, which is something that is very easy within a few minutes that you can gauge an idea of the patient's physical well-being. And essentially in the frailty score 1 to 3 are you're fit and healthy, or they have manageable chronic illnesses that they can render stable with medication. And of these are your general population that you would be quite comfortable working with their health or even elective cosmetic demand and so forth. But if you begin to have a person who scored 4 or 5 coming into your space, and again, I highlight this frailty score does not only apply to age 65 and above. So you can apply these to your younger patient who may have other medical conditions that they present with or they have to live with. So, but if they are beginning to be in the 4, which is vulnerable, or the mildly frail, number 5, I do highly recommend that you do need to work together with the GP to get a bigger, more holistic picture, especially if you are embarking to consider the full mouth rehabilitation. So some of the incoming question asking about is it worth saving some strategic teeth? Because look, it is, I think there are situations where you need to consider saving the teeth that are valuable and that there is confidence level to maintain, not without help. So the patient education has to be present, but these have to also match up with other modalities that you put forward to them. That also will need their own maintenance in itself. So this is where you may work together maybe before they start Prolia, example, would be in this category, before or the early diagnosis of Parkinsonism, where will we go? So there will be also from here a treatment planning goal shift as we move towards the frailty, because if there is expectancy of a person to continue to frail, moving through the score 6 to 7, which is moderately frail, so they become needing further assistance, not just from decision making or the finance capability, but more the day-to-day living. Scores 8 and 9 unlikely to really be treated in your common day-to-day. So these are your terminally ill. It is important that you understand with all these different types of oral complications that will continue to feed through, such as dry mouth, risk for mucositis, dysphagia. So, some of the post-stroke or just elderly patients who lose the tonicity in their tongue. Often, this is one other classic example where if you have a patient who's had a complete upper denture for a long time and they have done well with their complete denture, and suddenly after a reline, or a sudden complaint that they can't swallow, I do commonly see a lot of people start hacking the poststem or reducing the poststem. It's so important that actually to assess for these patients, is it that the chewing, the retention of the prosthesis that is causing the dysphagia, or actually they're having physiologically, they're losing the tonicity in the tongue, so they can't put enough pressure because maybe the palate is actually being thinned so much that they can't touch it to swallow, or there could be other reasons for their dysphagia. So it really becomes a multidisciplinary management for some of these patients, and fixed dental prosthesis is not always the sort of your perceived gold standard in the elderly population, because of the potential more difficult to manage from a complications point of view, as well as the more difficult to control in parafunction, and sometimes they may need other assistance for changing in the palatal contour. So there is no just one recipe for all, and I think because of these reasons, you do have to maybe unwind a little bit and come back to the core of actually understand the patient's presentation with particular disease, the etiology of why they are losing their teeth, and in the rehabilitation process, we do need to also see what is good that we could copy. Maybe perhaps is how their teeth once were if they deteriorated. And we can use technology, a lot of the CAD/CAM, a lot of the workflow still to facilitate us. But I would highlight, they are great to maybe make a treatment appointment faster, so reducing number of steps. They are also great to be able to generate diagnostic workup that simulate the old, so that the patient can find it more familiar and easier to learn. However, I do also think at the same time it could be very dangerous to utilize certain methodology just because the clinical workflow for the clinician is so simple, or because of this engineered workflow, it's a lot more affordable for the patient to just receive that treatment instead. Sure. Before thinking about all the different risk factor. But it's very exciting. There are lots of pockets of potential research and innovations, I think, to come. Yeah.
Oh, absolutely. Thank you so much, Agnes. It's actually quite refreshing thinking about such philosophical, hardcore prosthodontic treatment planning. Because I remember when I first started pros and listening to some of these conceptual ideas, at the beginning I had no idea what they were talking about. But now, it's actually with some years of experience, it's actually making more sense why sometimes take a step back, looking at the whole picture is actually so important. Because sometimes when you're dealing with a case, you are not thinking of the big picture sometimes. You're too quick to solve the etiology or the problem for the patient rather than the patient themselves. So thank you, Agnes.
If that was too philosophical, just in short, if you're ever taking a high-strung patient with very tight speaking space already talking like this, and you copy that, and then you go to a system where Ben's just illustrated, oh, there's no give in the implant, then they will be bashing the implants around, and then they have difficulty swallowing because the OVD is too far open, and you're sitting there going, I don't think they're too far open, but they just haven't adapted. Basically, it's just what I explained.
No, absolutely. Thank you, Agnes. And now on to etiology. We all know that identification of etiology, of why the patient got there in the first place, or why are these teeth failing in the first place, is so important, because if we don't identify them, manage them, mitigate them, or to prevent them, well, whatever treatment that you may do could fail in exactly the same fashion. Johnson, do you mind take us through what are some of the most common etiological factors in the failing dentition and what we should look out for?
Yep, thank you, Ben. The three most common causes of complication that can cause complication in the practice would be, one would be periodontitis, and then second would be any mechanical complication, and third would be psychosocial. With a patient with a history of poor oral hygiene, history of periodontitis, and smoker have increased risk factors for peri-implant disease. It's important for the patient to have the ownership of the problem, and it's important for them to understand even if their periodontitis are stabilized, and even if they have excellent oral hygiene, their risk is significantly increased. Taking this patient for example, he is in his early 30s, but he has a family predisposition of advanced periodontitis. He's a working professional, so he's finding that his gum recede. He's finding his aesthetic is getting a little bit unacceptable. We can see his oral hygiene is excellent and has been seeing a periodontist for many years. He even dipped his pixter in a bit of a chlorhexidine, so you can see all the staining in there. We discussed the option of saving as many teeth as possible by doing segmental approach, the anterior first, and then if the posterior fail, then we can do the posterior. But for him, he just wants to, he realized it's only a matter of time before he loses all his maxillary teeth. So he decided to do a full arch approach. So he decided on implants retain overdenture. So it's important that he's seeing a periodontist all the time in the meantime. But any point in time, or if you can see if there's any plaque around the healing abutment, you always reinforce to him that it's very important to clean very well. But for him, he always has excellent oral hygiene, and same goes as when we fit the locator abutments, he's cleaning very well. And this is the before and after. It's important to know and important to pick the right patient for the right treatment. Taking this patient for example, she had a very severe periodontitis, so we've decided to retain some of her mandibular anterior and some posterior dentition. And we can see we placed some implants, and then we decided to have a full arch fixed prosthesis for the maxilla, and then some splinted implant crowns for the mandible. But we can see this is about 9 years after the treatment. She was a smoker. She stopped smoking for a while, and then after a while she started smoking again. So we can see the significance of smoking that can affect the peri-implantitis and plus history of implantitis. The next part would be severe dental parafunction. For patients who can crack unrestored molar, we always have to treat them very differently. And patients with very severe dental wear, who can wear down their teeth, these are people who are brachyfacial, always treat with caution. Dental parafunction can be during the day. Some people, we all clench during the day, whether we are stressed, we are driving, or when we concentrate. It's how much clenching that we do that can cause the damage. Management including, people can set alarm, or people working in front of a computer can put sticky note. Some people put a rubber band. Some people have some writing in their hand to stop the awake bruxism. And there's the management of the sleep bruxism. So, when we do a rehabilitation, we always wanting to test them out. During the provisional phase, we can always give them different splints, can be bilemma, can be thinner splints. In the definitive, we can do the 3D printed nylon, which is a little bit more comfortable for the patient to wear, or the traditional acrylic. Even for patients who could not tolerate, I think it's important to give them like Essex appliances to test it out, at least, just to have some protection. Because if you don't manage the parafunction, anything can fail. This is a zirconia implant bridge that have a sufficient thickness, but still with a dental parafunction, it fractured. And patients can fracture their implants as well. So they can fracture the abutment screw, but we can see implant fracture as well. And there can be a loss of osseointegration due to overloading. The loss of bone pattern is a little bit different. So you see a little bit of a small radiolucency around the jawbone, and that is due to loss of osseointegration. When it comes to design of the implant prosthesis and implant planning for patients with severe dental parafunction, it's important to have a larger size implant and a smaller size prosthesis. Taking this case for example, the dental implant was a narrow platform implant done in Europe, which is quite common in Europe. They place a slightly narrow dental implant and they put a large size prosthesis. To replace a premolar, they put a molar size. So in this case, the patient presented with abutment screw loosening. So always warn, repeated abutment screw loosening is a sign of catastrophic failure. And then a year later, she came back with a fractured dental implant. So when designing the prosthesis or when planning for implant, it's important to have a larger size implant, which is a regular size, and a smaller buccal lingual width, a more premolar buccal lingual width to reduce the loading to prevent mechanical complications. Unstable oral health condition, many of these patients, they may have been seeing dentists for many years, but then with dentistry failure, then they neglect their teeth for a while, didn't go to a dentist for a while. It's important to assess their oral hygiene initially. Most of these patients can improve a little bit, but significant improvement is rarely seen in most of these patients in the long run. So for this patient, he has decided, he's not going to spend 10-15 minutes morning and night for a fixed prosthesis. So he's decided to have implants retained overdenture. Most of these patients, they only have to spend a minute or two cleaning the locator abutments, and most of them, even though with a inadequate oral hygiene before, they can do quite a decent job in maintaining the locator, and then it's a more sort of a long-term outcome for them compared to fixed prosthesis.
So we'll continue on onto this topic. The first session is more about the assessment, the planning side of things. What are the important factors to look for? And now we've determined that the teeth does need to come out, and we're looking at the surgical treatment of extractions or clearances. Thao, you do a lot of these. Tell us, what are you looking for? How do you go about planning for these things, and what tips do you have for us when it comes to the surgical management space?
Yeah. Thanks, Ben. So essentially, we've gone to a point where the patient needs a full clearance. And it's really important, these are the patients. This is an example of a 65-year-old male, severe dental anxiety, dental mistrust, and a poorly controlled diabetic. So if we're planning a full clearance, what are the expectations we have for the patient? How can we plan the extractions? What do we tell the patients, and how do we temporize the patient? They're concerned about their appearance, and how long is this procedure going to go for? People have busy lives, and so we need to also take that into account. So a few things I often consider when I'm removing a lot of teeth or doing multiple extractions is really deciding whether we can do this in a staged technique, or whether we do it single visit. It sounds a lot nicer to do single visit, but it's often not great for the patient because it's a lot to go through, and you have to really come back to judging the patient. And that's why Agnes's discussion about assessing your patient, the psychological aspect of the patient is really important. The other aspect is stage extractions might allow the patients to cope better with treatments. But for example, if a patient's requiring preoperative antibiotics or antibiotic cover, are we going to give them AB cover multiple times and prescribe them antibiotics multiple times? Because where does antibiotic stewardship comes from there? Are we doing a disservice to the patient? And also, if we're needing to disrupt their, I don't normally stop their anticoagulants, but in some cases where you have high risk, then you might need to. So are we needing to stop them every time? So that needs to be taken into account. And then add on to that, can the patient deal with treatment in the chair? If they're getting to a stage where they need a full clearance, they're probably dealing with a lot of dental anxiety and dental fatigue, and they might not want to be doing these multiple times in the chair. So we need to think about options for sedation and general anesthesia. And then importantly, you need to also discuss with their medical practitioner. A lot of times I'm talking to their GP, there's other medical specialists, their general practitioner, their general dental practitioner, their other specialists as well, to really bring together their overall health of the patient. Some patients only have a window of treatment, so I get a lot of referrals where they, especially from oncology, where the patient's starting radiotherapy next week, we need to get a full clearance now. And that gives time limitations for the patients as well. A lot of another aspect that people really don't consider is the effects of nutrition on healing. Because if we're doing a full clearance, a lot of patients just talk about, we'll just be on a liquid diet. Now, liquid diets can often mean they're just on soups. But if you're thinking about a patient who's elderly, who has multiple medical conditions, and then you're changing their diet quite drastically, that's going to affect their overall healing as well. So again, your pre-operative assessment of the patient and telling them, prepare yourself for this treatment, and making sure they have an appropriate dietary advice is really important. And in some cases, if you're not removing all the teeth, but you're removing a majority of the teeth, you need to understand that there's some of their teeth are heavily restored, so some of them will easily fracture. And so if your patient is awake and you're removing a lot of teeth, think about little bits of fragments of teeth coming out, the safety of the patient. You don't want them to aspirate any of so you and your nurse and your assistant needs to be really on the ball when it comes to multiple extractions. And then adjacent teeth, making sure you don't damage adjacent teeth. And as I mentioned, post-operative care, making sure they know what to expect. A lot of patients who are older, they've had teeth removed previously, single teeth, and they kind of expect the outcome to be the same as previously. My last extraction was when I was 28 and now I'm 80 something. And so they need to be really aware of what the outcome is like for them. So this is just an example of a full clearance a lot of the times we think about trying to preserve bone. You know, we're always thinking about, socket preservation for implants. But when we do a full clearance, it's really important I'm liaising with the prosthodontist or the restoring dentist, because a lot of the times you need to think about restorative space. You need to think about, if the patient has exostosis, tori, that's going to affect their prosthesis. And if they're getting a full clearance, you want to have that bone reduction and that management, the osteotomy, before, at the time of the extraction, and not after. You can't imagine the patient's going for all this treatment and afterwards, we're going to go in and remove bone. We're going to do a tori removal. And so this needs to be planned ahead. So a lot of the cases when I get referrals from the group, I often check, they actually mention 5 millimeters of bone removal or bone removal down to the apex of this tooth, and I normally follow that, and that's important, and that's why liaising with being a group member and talking to all those involved with the treatment is very important. And this picture here, you show that there's importance of bone reduction. There's no sharp edges. There's nothing worse than a patient coming back and they've got bony specules coming through and they're in discomfort, and especially since they're already anxious and now you have to go through the procedure again. And then you get primary closure. A lot of people often ask me what is best in terms of primary closure. So first aspect is that they ask me, do I do the alternating papilla treatment, where you take out the teeth and then you have a pill and you try to do a crisscross part. That can work well for a patient who has a thin biotype, because you're trying to maximize the keratinized tissue in the area. But often it gets messy, especially when patients have an excess of tissue or they have a thick biotype. So I would be looking at bringing together tissue, seeing if there's any excess tissue, and removing it appropriately for the patient, being mindful of the amount of keratinized tissue present. And in terms of suturing, a lot of people ask me, do I just use a continuous suture? Now, if you're doing full arch suturing, what happens if you do a continuous, you kind of focus on one area, and by the time you get to the other side, it's quite distorted. So my recommendation is actually doing just simple, at least two simple posterior, anterior, and then when you have everything in place, then you can think about doing a continuous to finish things up. And you need to think about why you're suturing. You're suturing to approximate the tissues, but often to control bleeding as well. So the type of sutures you use will depend on that as well. So the expectations, look, as we think about our patients, a lot of our patients are older. There's polypharmacy and limitations to oral hygiene, compliance. So the main issue is delayed healing. So what often they get quite significant swelling. There's dehiscence of the area. So it's important to kind of gauge our patient and appropriately prescribe antibiotics. Think about prescribing a corticosteroid like dexamethasone if you're doing quite a large surgical procedure. And a lot of these patients who are older, they have chronic disease, so they can't take, for example, some patients can't take NSAIDs, and so they have an issue with pain relief. So you need to consider, you can't just rely on just your post-operative pain relief. You need to think about, maybe I'll think about doing a long-acting local anesthesia like Marcaine, which I normally use under general anesthesia, just to get them past that initial pain barrier. And I also often give them preemptive analgesia. So instead of just waiting for them to go, take the painkillers when you get home, I actually give them painkillers at least an hour before, or at least make sure that they, they prepare for, rather than waiting for the numbness to wear off. Now, bruising is often quite normal for patients who are older, and you need to set that expectation for them. I've definitely done quite straightforward extractions, and the patients come back with a face all bruised up, and it's quite shocking to see. But now, as you get more experience, you realize patients are older, and it's not just those taking anticoagulants. There's with age, you find that there's fragility of the vessels, the fragility of the mucosa. So these patients tend to bruise a little bit more. And rather than trying to avoid bruising, I would just go, this is possibly the expectation, and then also supporting them if it happens. I often see, what I'm seeing a lot is these liver clots that often occur with patients actually taking some anticoagulants, and they come back with these big exophytic kind of blood clots that, and every time they bite on it, it bleeds, and it's quite scary for the patients. And if you don't know what to do, some patients just keep biting on it and it keeps oozing blood. So the best treatment is actually to anesthetize your patient. This often happens only a couple of days or a day after surgery. Anesthetize the patient, remove that blood clot completely. So a lot of people are scared to disrupt it. I would remove it, curettage the area, pack it with a hemostatic agent like Psychosocial, and then achieve closure, and that often fixes the problem. So this is, and I'm tending towards a lot more of these atraumatic extractions. And when I say atraumatic, I really mean minimally traumatic, because we're taking a tooth out, so there's some sort of trauma. But an example here is you have two teeth. They both need removal as assessed by the endodontist. And so you're looking at the 1.7 and the 1.6. And when you look at it heavily strawed, big crowns, you got a big filling in the 1.5 that you don't want to fracture, and the bone, you can see that the buccal exostosis happening. So you can imagine just putting forceps on the tooth is just not appropriate. You're going to damage something. It's going to be uncomfortable for the patient. So in general, what I tend to do now is I decoronate the teeth, and I think it's quite scary for people to think about decoronation of teeth, because we always like the idea of having something to grab onto. But what decoronation does is minimizes your risk of wanting to grab the tooth. Secondly, it allows you to look at the root morphology a lot better, and then allows me to then section the teeth based on what I can see with the root canals. That guides me on the number of roots there are, and then I elevate within where I've actually sectioned. So there's no elevation at the mesial aspect of the 1.6, which you risk dislodging the filling on that 1.5, and then you take out the teeth with very little effort actually, and then I normally place a sponge stand. I place some sutures over it, but you can see that is why I call minimally traumatic, because you haven't removed any bone, and you really where you're sectioning, the tooth's coming out, so the patients normally have very little pain and discomfort associated. And then important bone reduction. How important is that? So this is just an example of a patient who was referred to me for the removal of the 3.5. You can see the 3.5 there, and the patient's actually about to start prolia, but you can see that exposed bone on the lingual tori, and patient says that happens a lot to them. And for me, the idea is if you're going to remove teeth, think about, even though they've had it there for a long time, they've had no issues with it, they just notice every now and then it gets traumatized, you need to think about planning in the future when the patient's about to start their journey of prolia or other medications that would change, because our patients are dynamic. So our treatment planning needs to think about taking into account those changes, not just the treatment at the time.
Terrific. Thank you so much, Thao. Lots of pearls of wisdom there. There's some questions regarding sutures. What's your favorite suture to use? Any particular reasons?
So previously, like in GA, general anesthesia, they just they supply us with Vicryl. I actually don't like Vicryl too much because it's braided, and I find that what happens is you get that plaque accumulation and erythema of the tissues afterwards, and the patient complains about that. So I'm actually leaning more towards the monofilaments like Monovec, and I would only use non-resorbable if I'm concerned about the dehiscence of the graft. And normally if I'm doing a large or anterocommunication closure, or if I'm doing quite extensive grafting, I think about doing using a non-resorbable monofilament. So I'm definitely going towards monofilament, and I tend towards the smaller ones now. So previously, when I was doing a lot of oral surgery at the dental hospital, I use a 3.0. Chromic gut, which is, and then we're told that if you're good at chromic gut, you're good at anything because it's a horrible material. But now I'm heading more towards 5.0. Okay.
The patients tend to like things like Vicryl because it's so soft.
It's
quite comfortable as opposed to your monofilament
Yeah.
absorbables, which sometimes can feel like fishing lines in
Yes,
their mouth.
yes, yes. So I think it's you've got two elements there. So you need to kind of tell the patient what to expect. And a lot of the patients with full clearances, we're actually supplying them with a denture.
Yes.
So it's actually covered most of the time. So for me, I prioritize oral hygiene and the recovery of the soft tissue over how it feels for the patient.
For sure,
Yeah.
for sure. No, absolutely. So now that we've got rid of some teeth, I think the patient might be ready for a denture. So we're talking about the following option, which is our conventional removable full denture. Agnes, I know there's different classifications and assessment for patients on full dentures. And also, could you take us through perhaps what are some of the key elements to perhaps achieving a good conventional full denture?
Okay, thank you, Ben. So let's have our beginning slide with this patient that presents clearly with hopeless prognosis of all these dentition. And there could be many ways of the treatment modality. So, but at times, because of the active periodontal disease that is there, sometimes we do get a request from the periodontist so that we have to go through the aspect of clearance and have to delay placement. There are a few benefits in doing that. One is we are able to have a time frame to manage the disease, to clear that. Secondly is that we can allow the patient a little bit of period of healing and screening of how they may feel with the removable prosthesis, etc., and so forth. So I think understanding removable prosthesis and being able to screen whether what type of patient is possible to have a go at exploring removable prosthesis is very important. So, but when we are embarking on making people removable conventional prosthesis, we need to make sure that the expectation is well aligned. Often I do remind them that these are either temporary or indicative removable prosthesis. As a removable prosthesis that is otherwise not very invasive, the complication rate in terms of a bodily health matter, it's quite low. It's just temporarily facilitating their aesthetic and a system with a bit of function. They do have to respect it's like learning how to ride a bike. So that learning new skill element is put in as an expectation from the beginning. And a reminder that the musculature, how they move, can move the prosthesis. So that it needs to be realistic, so it doesn't just end up with the patient wanting more than what really the removable prosthesis can achieve. And as you're conversing with the patient about these aspects, you can then decide whether or not you can assist with attempting this fabrication yourself, or is this a patient that is suitable to go through this at all, or is better to refer. So the predictors for conventional complete dentures, this is, I'll cover both upper and lower. We got to look at the anatomy. These are the organic things that we can assess. The patient factors, which a part of it we have already covered. So the age, health, but mainly honing in on the learning capabilities and adaptation assessment, the denture mechanics, as well as the adaptation process. So with the anatomy, it is, most of us will know the maxillary ridge, both the height and the width of the hard skeletal structure with the alveolar ridge is the main determinant for success, because this would allow us to give the support, and having very nice firm tissue is also important for the stability of the denture. Commonly a U-shaped arch is a bit more supportive. So when we are looking at the maxillary arch, I'd like to refer to the American prosthodontic classifications of the edentulous ridge. So for those who may want to follow up and read a little bit more on, you can do so. So if you have evenly a good height and width of the ridge throughout the anterior and posterior maxilla, and nice, firm, non-inflamed soft tissues, and not a lot of mobile tissue with relatively high frenal attachment, then you have quite a good success rate with your maxillary conventional dentures likely. The next layer of challenge would be having more fullness of the anterior ridge but quite resolved posterior, where the hammerless notch area is becoming a little bit less marked. That would be the next, but having a strong premaxilla is still very helpful to fabrication of conventional full denture. More challenging would be actually a lack of the anterior maxilla, but quite prominent posterior maxilla available. So this is typical of your combination syndrome, where patients may present in that way. And of course, very, very difficult class D would be the atrophic maxilla. So just a walkthrough with what we would expect in your impression is that, your papilla area, whether you need to provide any relief. Of course, in the posterior maxilla, it's hard to just zoom in, but what you want to actually do is you want to palpate. So these are the compressible area of your poststem. So your poststem doesn't actually just have to be a line at the R line. It can take in the form of Cupid's bow, and the way you decide how much you would take that pressure would be determined how compressible the tissue may be. So other aspect is you can actually see the sulcus area is captured both in height and in width, and here you can see the frenal attachment, and here you can see the hammerless notch being clearly defined. Here you can see the darker blue would be the border molding, where you want to selectively compress the tissue that allows the compression, and then the whole detail surface is taken with the light body. If you do find that there are more inflamed tissue, flabby tissue, that could be more vulnerable and mobile, often in the impression technique, you might make relief area either opening a hole or having more spacer in order to be able to capture these relatively mobile tissue in a more static manner so that you don't overcompress them. But it is important nonetheless to recognize this so that you can, again, set that expectation conversation up with the patient that if there is a lot of mobile tissue, it does influence the stability. It doesn't matter, you can have the best suction, but when the patient chews on it, it's like the whole thing sort of moves. And that's what we're referring to by the stability of the denture. Anatomically, in the mandible, again, we can more look into the hard and soft tissue, mainly, in particular the muscle attachment, in terms of grading the classification of what can we deem as a success rate. So broadly speaking, from the bony height and width, if it is measuring more than 21 millimeters, then you've got really good height of the ridge for support of your mandibular denture. And as you can see, they're listed on the slide as this gets lower and lower, more down to basal bone, lacking the height of the ridge, then you have the more difficult in the type 4 aspect. And equally, depending on the muscular attachment of the buccal frenum and the mentalis area, the tongue, the lingual frenum, whether its attachment is still in the in the alveolar mucosa or more in the attached mucosa, these will influence the prosthesis stability. What is more important also in our complete full denture in the mandible is also, if you take a look, so it doesn't really matter the type of material used for your capturing of the impression. what matters is understanding the viscosity of your material that you're using to be able to do the selective mucocompression compression as you move along. So here what is important to see is that we want to assess and be able to capture the retromolar pad, whether we have a nice spongy pear-shaped retromolar pad, the retromolar hyoid area, if we do have, again, some springy tissue here for any compression. Of course, along the ridge itself, again, it's more rare to have more mobile ridges, like flabby ridges, but they can exist. So, of course, during the impression, so that we want these functional aspect of seeing the nice lingual frenum, buccal frenum, and of course how everything sort of comes together. So the way we assess the success of a set of complete full dentures, or even if it's opposing dentition, is we got to also look at the maxillary mandibular relationship, because the way our teeth comes together sets up a lot of the dynamics in the denture occlusion and the mechanics. So basically, the ACP classification will look broadly in these anatomical aspects, the MMR, and in summary, if you have more of a class 1 relationship, if you do tend to have more a type A maxilla, so very nice broad ridges, and if in the mandible you have more type A and B, then that's a pretty good combination for people who want relatively easy anatomical presentation, that they can have a go at these complete dentures. It does get a little bit more challenging. Basically, in this ACP class 3, it would begin to involve some pre-prosthetic surgery, and definitely class 4 would require your surgical intervention, such as what Dr. Thao has gone through, any removal of tori, any vestibuloplasty to lower any muscular attachment, or of course the other surgical intervention is with the help of implant placement, so that we can improve the stability and the retention of the denture. So just a quick walkthrough after explaining the assessment of the ridge. In this particular case, you can see is rather than muscle frenum, you get a full muscle band happening, and we have a loss of the ridge height, both in width and in height. So it's relatively quite challenging, but what we do have is a lot of spongy tissues and borders. So this is a very good view to reflect the very first primary impression that we often take is one that is overextended. And equally, you can see that you can have this retracted view and do your scan for those who are into scanning. Because from here, essentially from the analog version, you would want to mark where your potential tray extension be. So equally, once if you have this scan image, you can mark an area where your denture base could be a nice fitting surface, but a little bit short. So these are some of the analog images where you can see this is a close fitting tray, a little bit shy of where the depth of the sulcus is anticipated. We of course want to make some freedom for where we expect the frenal band of tissue would be. Usually in the mouth, we want about a 2 millimeter clearance, because we are going to adapt the green stick here, where we are able to soften it in, so it becomes really pliable, and just take that measure in the mouth. So after we have selectively compressed the area that are spongy, so in this case, which is the spongy retromolar hyoid fossa region, as well as the retromolar pad, we can now just do a nice wash to allow us to have our final impression. So the OVD assessment commonly is we will have the prosthesis in place. It's very important as we assess them to their speaking space, the M sound, or looking at the facial support if you're just looking at facial tone. But bear in mind how much freeway space you give them goes back to what I have referenced. So this is regardless of our prosthesis. Removable only means that patient can take it out and have a rest during the adaptation. So this technique is applicable whether you are planning fixed or planning implants or whatnot. So the adaptability and the amount of freeway space, you have to look at their past rehabilitation history, how quickly they can adapt to even new restorations or changes in the mouth. You look at their age. You look at whether they have any chronic diseases presentation. You do also look at their personality traits in terms of their whether they respond well to changes around them easily. It's as simple as that. So for those who have some parameters that you have doubt in terms of being able to adapt well, as well as those who are a little bit more class 2 in presentation, you do want to give them more freeway space than your usual 2 to 3 millimeters. And also those who you observe, instead of just their facial tone, if they tend to be quite strong with their masseter, they chronic clenches, you can see the mandibular notching. If you ask them to say M instead of a very nice soft face and go M, they tend to speak like this and go M like that, and that's where the M is. So just be mindful. You would need to allow more freeway space for these people. So you can mark them. So the good thing about the workflow with the digital printing, the base plate, you can also have an MMR, which is not dissimilar to getting a set of their old dentures to duplicate, so that then you could actually capture the secondary impression in a closed mouth technique at the correct MMR to achieve to this next step where you can then try in their teeth and issue the denture. Bear in mind, when you're issuing denture, in particular the lower denture, it's so important to disclose functional disclosing. So what I mean by that is the use of pressure paste, or in this case, I can see here Dr. Lee has used a fit checker, so that you can further disclose any soft tissue that might have been a bit more mobile and been compressed during the fabrication, so that you can ease this area accordingly. You will be able to see in this video that he was able to deliver a very nice suction denture that can be achievable, at least at the point of static. So when patients are functioning, this is another point where you have to deliver. So most of the time we do not replace the second molars, only because it can really impact on the stability. On unconventional dentures, we only go up to the first molar, and you really have to counsel them that they can only chew up and down rather than a lot of the side movement. And this is because everything is habitual, it's sort of in the central pattern generator. So you do have to remind them that you are fine-tuning, you are having these new skills, and regardless whether they stay in the removable prosthesis or once they actually train to a more favorable chewing pattern, they benefit with less mechanical issues too in whatever prosthesis to follow. So it is these are what I really value as a rehabilitation process for patient, because you don't want to duplicate their heavy function or their lost OVD from pathological parafunction into your new prosthesis, only to bash your new prosthesis around. Because in a removable pros, the prosthesis moves. In fixed pros, your prosthesis doesn't move, and the force has to go somewhere, and it becomes your problem if it is your prosthesis that is breaking now. So one thing that is so important, again, you can see these beautiful impressions that you've taken the time to capture. So important that as you send it to be poured up, that the person who are constructing this model can respect to fully able to replicate both the sulcus height and the width. in order to be able to then follow through with your prosthesis. So just a recap, there's the patient age factor, health-related factor, but also that psychology, and it's a rehabilitation process.
Absolutely. Thank you so much, Agnes. It's the full dentures are almost like a dying art that less and less of us tend to do these days. But in full mouth management, from my point of view anyway, I think it's so crucial, and there are so much things we can test. We can test the patient's psychology, adaptability, as Agnes described, patient's phonetics, muscular treatment, ink changes in OVD, TMJ, everything that you may want to do later on with implants. And sometimes it concerns me where failing dentition from A to B or A to Z with straight away implants in, fixed prosthesis on, while there might be a completely feasible modality for us to do, but what if the patient can't adapt to it? Well, where do you go from there? It might be a very challenging thing because there was been no test during that process of time, whereas it gives you and the patient a lot of time to figure them out, or for them to figure themselves out, what might work and what certainly doesn't work. And then you can use this as a template to move forward. So thank you, Agnes. Now moving forward, there are some patients that sometimes prefers to have a more stable prosthesis. So perhaps we could consider the next option, which is using implants to help us to retain these removable prostheses. Zoe, could you please take us through what are some of the options available? What's the difference between the maxillary and the mandibular overdenture sometimes, and what usually is the treatment sequence?
Sure. Thank you, Ben. So in terms of implant patients who might be partially dentate and looking for more stability or support of their prosthesis, and what we can look into is how well are the teeth, and as we know that a lot of people are changing the positive mindset of trying to preserve their dentition as opposed to extraction and full arch implant cases, and we do encourage that in the practice. If the teeth are quite restorable, they're in a good periodontal restorative status, then how can we improve those teeth and preserve them for the patient? So provide them with a prosthesis that is cost effective, easy to maintain, and also well supported and retained. So for instance, in this case here, where you have teeth that are distal, so class 4 Kennedy classification, you can improve the retention of a removable denture by designing some crowns with rest seats, guide planes, palatal shelves, so very basic prosthodontic work, but it does improve the outcome for the patient. So when we have to communicate our treatment plan early on in terms of our crown design, for example, where do we need our retentive element on the crown, so we can instruct our lab to make the denture. So all the retainers might be approaching from the distal aspect of the tooth, engaging a undercut on the mesial buccal aspect of the 6 crowns on the 6s. And that way, the prosthesis will become less visible when the patient smile, plus it's less cheek catching for the patient. So it can give you a deceiving look that it's not really a denture because your retainers are quite far distal, and it's such a simple restorative option. Now, if we have this similar class 4 Kennedy classification and we think, all right, well, the patient might want a little bit more retention, a little bit more support for the prosthesis, then implant utilization might be suitable. And in this case, just simple 2 implants where the bone is good in the anterior maxilla with locator, abutment. It will retained in a denture. So remember, we have to make a cobochrome casting denture that will incorporate the housing of these implants. So normally this design can be done as opposed to a full palatal coverage. We can get away with a horseshoe shape design because we're still gaining some support and retention for the denture. We're not so much relying on the palate. So that will give the patient a nice, very retentive prosthesis that is also cost effective. So again, another case where we have to really think about, do we sacrifice all the teeth, or can we offer a bit more simplified approach, and utilizing things like extracoronal connectors, for example, on the distal of the 2-4, or sorry, the 1-4, and then some locator abutments. We completely can give the patient a denture that incorporate these locators, as well as that retentive element on the crown. And looking at it, you camouflage that sort of emergence. So we don't really need to have any retainers on the central or the premolar, where it really impacts the aesthetic outcome for the patient, and provide something that is quite supportive. So sometimes we may resort to these consideration, and offer them as our treatment plan for the patient before we embark on full arch clearance. Now, traditionally, if you think about overdentures, I mean, they were introduced first on teeth. So teeth are not suitable to have crowns, or be abutment for bridges or abutment for dentures. So they come in the form of like a studs, locators, or even bar attachments. They utilize these teeth have to be, of course, endodontically treated. We aim to have the tooth extending above the gingival margin by 1 to 2 millimeters. And then by preparing a good root canal, having a sound endodontic treatment with a long post prepared on these teeth, and a gold cap that will engage the post space as well as the root space. A locator attachment, whether it's soldered on to this gold cap, can offer the patient a resilient attachment to the denture. So you've got some movement of the denture, because it's not a rigid attachment, but also it offers quite a good utilization of what's left in the patient mouth. So this may be considered for patients who are medically compromised, unable to have extraction, and we really want to improve on the retention of their prosthesis. So that might look something like that. So root stumps, and then we can utilize the remaining teeth to improve our outcome.
Patients on Prolia, for example.
Yeah, definitely. Okay, but in other cases where you have the patient might have lost all their teeth, they say fully edentulous, then we do have some options to consider. When it comes to a removable prosthesis, we may consider a implant supported removable prosthesis, for example, on the this kind of prosthesis on the left-hand side that's implant supported, or an implant retained. So the difference will be is the implant supported, you're relying on the bar and the implants for fully support the prosthesis. You're not so much relying on the tissue or mucosa. Where implant retained, you're relying on the mucosa to support the prosthesis, and the implant is just for the retention of those. So when we come to an implant retained, then we have the option of whether it's a stud abutment that we use, ball abutments, or a bar and a clip. Now with these, because it's such a simple, easy treatment in terms of low cost for the patient, easy to clean, kind of easy to maintain as well. But we do have to review these patients and maintain them, because these locators and attachments will wear down with time. They become non-retentive, so they will need to be rechanged and reviewed at least once a year. And also because the denture is supported by the mucosa, we'll have to consider whether we need to reline that prosthesis for the patient as well. So I'll share this case that we touched on earlier on with Dr. Lai, and that patient who had received a removable prosthesis in the mandible, removable denture. He wished to have something a little bit more supported, or better retention for the prosthesis. He wants to be able to chew a little bit better. So what we can consider is, of course, one of the option is the removable implant retained or implant supported option. So what we need to start with, of course, is now we have the denture, is we design a radiographic guides. So this can be easily done when the patient come in for your visit, is we take a copy of the denture. So it's either scan and print the denture into a radiographic guide, or you can take a putty key replica of this denture and then pour it into a cold cure acrylic or heat cure acrylic. The lab can make it for you, and that will give you a clear radiographic guide. So when the guide comes back in, then we need to incorporate some sort of a radiographic marker, so we can design that guide to act as for the dual scan technique that we'll carry on. So these markers, they just little depressions that we cut into the denture, maybe 1 millimeter deep, 1 to 1.5 millimeter wide, and then you fill them in with gutta perca, or cover them with barium sulfate, and that will act as the radio opaque medium in the scan. So here you come, the denture. So you might consider putting 4 or 5 little markers on the lingual aspect, 4 and 5 on the buccal aspect, and they in different vertical heights on the guide. You try it in, of course, so you've got to bring the patient back in, try the guide, make sure it fits well, it's seated as you would expect it, the occlusion is accurate, and then if we feel that maybe we are not quite, the guide is not supportive or retentive enough, then we can use a bite registration material to stabilize the occlusion. So when the patient have the scan, that material stabilize the lower denture, so it doesn't move, as well as act as a separating medium between the upper teeth and the lower teeth, just to give us a bit of a separation in the scan. Okay, and then what happens after that is you send the patient for the scan. So we'll scan the radiographic guide on its own, and then we'll scan the patient as well, wearing that radiographic guide. And when we import the DICOM data for the guide data as well as the patient with the guide data into our planning implant software, we can actually have marry or align all the markers of the on the guide with the markers on the patient scan, and that alignment will help locate the guide onto our model or onto the jaw. And then we can start our planning process. So you can see the outline of the denture, or where the teeth supposed to go, the denture was supposed to go in relation to the bone, and accordingly we can plan our implants based on that. So depending on the number of implants you choose to place for that particular patient, you can also remove that guide on and off. So it offers us a lot of flexibility. Once we're happy with the plan, then we can proceed to having something called like making a surgical guide. And the anchor pins are quite useful to help stabilize our guide. And we get the guide printed. And of course, that guide is used to place the implants. So this is a pilot guide, will help for the initial drilling for the implant position. And then once that's done, we can move on to removal of the guide and follow on with the completion of the implant surgery. So it's important to instruct the patient at that stage not to wear the denture for that 10-day period after the implant surgery, to allow for that soft tissue healing. And also we want to bring the patient back to be able to adjust the denture and ensure that there is no pressure on the healing abutment at all. So when the patient comes back, we use a fit checker, ensure that we adjust, cut away any marks that might be showing through the fit checker on the denture, and until we get sufficient thickness, and usually a 3 millimeter thickness of that fit checker on top of the healing abutment is what we look for. Realign the denture to improve the fit with a soft tissue reline, and of course cut away any excess material on top of that, because even that it's a soft reline, it does tend to harden up, and usually within 2 weeks you find that it's going quite hard. Okay. So now once the implants have healed, then we are ready to proceed with the next step of the procedure. So this patient's planned to have a implant retained removal prosthesis. So we are choosing a locator abutment. And as you can see here, there's a difference between the height of the healing abutment. That might be 3 millimeter healing abutment. The corresponding locator abutment is much taller, even though it's a 3 millimeter locator abutment. So the things we need to consider is where is the height of the tissue. So we might take the healing abutment off, measure from the implant platform to the highest part of the soft tissue, how many millimeters, and according to that, we can decide on our cuff height for the locator. And sorry.
That's all right.
Thanks.
Yeah, so as we can see that there's these locator abutments, they can certainly come in different heights depending on the soft tissue cuff thickness, and typically you just use a periodontal probe and you just measure from the shoulder of your implant to the tallest height of your gingiva, and that will give you whatever millimeters, and then you choose the appropriate locator abutment, which will automatically have 3 millimeters on top of it, which is the gold bit that sticks out of the gun.
Yeah, thanks, Ben. Thank you. And then again, looking at the housing and the retentive element inside that housing, so the inserts, of course, they come in two different types. So you've got the dual retention and the extended range. And what we can see here is with the dual retention or the extended range, they come in the removal force. So each one is how retentive it is. So they have different color coding, and each color will have a certain retention. So you need certain amount of force to be able to dislodge it. So some patients, if they early to or new to the removal prosthesis, you might start with a lower retentive force, and then gradually, as they become more used to being able to remove that prosthesis, you might increase the retentive force of that insert. So the advantage of having the dual retention is you've got the little rubber part that sits inside the locator, and then you've got the retention from the outer perimeter of the locator. And this will allow, because of the dual retention, it doesn't allow for a lot of angulation change between the inter-implants. So up to 20-degree inter-implant angle difference is accommodated by that kind of inserts. Whereas if you have the extended range, which allows for a little bit more because it doesn't have that little sort of rubber piece in the middle. So up to 40-degree of inter-implant angle correction can be accommodated by that. And there's some locators that will allow up to 60 degrees, so depending on what you use. Now, it's important to consider that if you're planning for a removable locator retained denture, the implant need to be as parallel as possible. So that will minimize our inserts wear, locator wear, and also problems with the denture stability and retention. So if they're not parallel, maybe things will not marry as well in terms of these retentive elements, and the patient will have more problems of not being able to see the denture well as going through these inserts so quickly and so often. So things that this is offer the smallest height in terms of restorative space needed. So with the locators, up to 3.5 millimeter in vertical height is what's needed for the locator itself, but then you've got to consider your denture space on top of it. And the other thing is important to think of is also the width of this locator. So normally the housing might need about 5.5 millimeter in width. So that takes quite a big chunk of your denture space. So therefore, it's always important to reinforce this denture with a cobalt chrome casting, so there's no issues of weak acrylic that may fracture. And it's very common in acrylic denture, fully acrylic denture that's not reinforced to fracture like that at the weakest point of the insert. So now that patient has, we chose the locators, and these locators have been selected. So what we can do now is to start the process of making the denture. Now we do have either we can use a special tray. So initially you've got to put the locator impression coping on top of the locators and then seat your impression tray. So instruct the lab to give you enough space on top of it to accommodate for that extra height on top of the locators. So you might space it out quite a lot. So you try in your special tray to make sure there's no contact whatsoever between the tray and the housing and the impression coping for the locators. And then we take the impression with a PVS material, following what Agnes has talked about in terms of the denture protocol with the border molding, good extensions, avoid pressure points, avoid overextension of this denture. So this tray has been tried and tested. Alternatively, if you already have a radiographic guide, perhaps we could use this as a pickup of the secondary impression of the denture. And the advantage of this is you already have your vertical set, your AP set, so tooth position is almost there, so patient was happy with the denture. Then we also hollow the space over the impression coping and ensure that there's no contact and there is sufficient clearance for the material to flow. So sometimes we might perforate that through the occlusal aspect so the material can flow out of it. So once we've taken our impression, then the lab can set up the teeth because according to that vertical, so we try in the tooth position, make sure the patient's happy, we check the occlusion, and it's quite important to ensure that our occlusion is accurate, so there is no pressure points and overloading of the implants there. And this is the finished final product. So check your excursive movement, so balanced occlusion, your lateral excursion, so to minimize any displacement. Now the lower denture is a lot more retentive. We don't want to create any issue of displacing the maxillary denture for the patient. So once we're happy, then we can review this patient. Usually we'll say come back once a year to check on the inserts, the housing, how well they clean, denture, whether we need denture reline or not, and to check the occlusion again. So in the maxilla or the mandible, whether we end up looking at splinting or not splinting our implants, there's various considerations. So when we talk about splinting, that's joining the implants together with a bar retained with a bar that will sort of create a mode of cross-arch stabilization. When we don't splint, then they are non-standing implants. Now they both have advantages and disadvantages, and I suppose when the bar is splinted, we think about the forces. The thinking is the more favorable distribution of the occlusal forces onto the implant. So there's less pressure on the bone because the prosthesis is purely retained and supported by the implants and the bar. So there's really no pressure on the mucosa as much. So less maintenance in terms of prosthetic wear, less maintenance in terms of needing for reline of the denture, and less risk of overloading individual implants independently. Whereas because there's a bar, it might be difficult for the patient to clean this prosthesis. So we need to consider how well the dexterity of this patient, are they able to clean it. Now, there are some reports of increased peri-implant mucositis in patients with bars, but most of the studies that looked into the long-term survival of implant in splinted, unsplinted design, they found that really there's no significant difference in both approaches or protocols, and also the peri-implant health on the long run, they seem to be comparable for both of them. So if we don't splint, like in these 4 locators here on your right-hand side, then we have to think about the forces that are transmitted to these implants. So we choose the patients that maybe not at risk of overloading these implants independently, which may lead to bone loss. And we need to think about, because the denture is supported by the soft tissue or the bone, so there's naturally more forces are transmitted through the mucosa into the bone. And we expect to have more bone remodeling, more bone resorption, where there's a lot of pressure applying on the bone. So maybe there might be more need for a reline for this patient. So when to consider to splint, things that are important is whether the implants are placed in soft bone, how well supported and retained those implants. So in terms of are they been placed in soft bone or whether it's a grafted bone as well. Is there patient risk factors, for example, people who have parafunction? How well aligned these implants are? The angulation, is it angulated implants? Especially if you distally angling some of these implants, then we won't be able to provide a prosthesis they have to be splinted as opposed to just long-standing implants. And other parameters, for example, if the patient has it's a cancer patient, maybe they have a cleft lip palate, you don't want any you don't want to rely on the tissue for the support, so splinting is important. And also where the restorative platform might be quite distant away from the bone implant interface. So in that case, for example, zygomatic implants, in that case, they will need to be splinted. So things to consider when we splint these implants. So studies that looked at for example, the Stompers and Cole 2011, they looked at this systematic review, so there's a literature review. They looked at 6 studies, assessed implant survival for more than 3 years. And these studies, they found that there's really no significant difference between splinted and splinted. They also found that the peri-implant mucosal health and bone health was quite similar between splinted and unsplinted designs. They assessed in terms of prosthetic maintenance, and they found that there is more need for prosthetic maintenance in the unsplinted. Especially if, but they also found that there's more prosthetic maintenance if you have a bar and clip, for example, or a ball as well. So studies tend to vary. Success rate seems to be quite high for both. Mandible, of course, always had a higher success rate than the maxilla. So when we consider whether we're going to go for a bar to splint the implant, we need to think about, it's important to plan this process right early in the planning phase. So at the time when we make the dentures for the patient, at the time when we assess our diagnostic wax-up, because we need more than 40 millimeter of space if we are to splint. And we need to know where our junction, so the restorative, prosthetic, and tissue junction between, do we have enough space to cover our junction? Is it going to be problematic to fit all the componentry later on? So we don't want to be coming back after we place the implants and thinking I don't have enough space. So that has to be planned beforehand.
That would be horrible. So one of the questions asking that you've covered some different attachments. We've got the stud, the ball, the bar. What about magnets? Are they falling out of fashion? Is it because of corrosion or any other problems?
Of course, I mean, magnets used to be used in the past, but they're no longer used nowadays because of the issue with corrosion. And plus they lose their retentive, like the magnetic retention quite quickly as well. So that has been phased out as far as I know, in terms of we now just rely on something a bit more easy to maintain, more available, readily available, such as locators. Okay. So again, the other consideration is cost. Of course, these prostheses will cost a lot more, and they're more complex. They require more hygiene expectation from the patient. So this case here, where we have a patient, lady presented with a severe periodontal disease. She was looking for implant retained, and because of the condition of her presentation, it was chosen to go for an implant support retained prosthesis. So after extraction, so there was full clearance carried out, the bone grafting that was required, implants were placed. Now with these implants, of course, the bone was quite, it's placed in soft bone. There might be so guided bone regeneration at the time. The history of periodontal disease and probably also the risk of overloading. So that place was planned for a splinted implant with a bar. So these bar, of course, when we make them, we have to make sure that that they are milled bars. So that there's this is a Nobel Procera bar that is milled. So try the bar in, ensure that it is passively fitting onto the implant. So you have to ensure that there is no tension at the screws, and take a radiograph, of course, to confirm the passivity of fit of the bar. Once we try the bar in, then we can have a look here and assess how much vertical height of the bar is needed. So 14 millimeter for the maxilla, where the bar is, in the lower jaw where we have a locator is a lot more forgiving in space. So we've got to make sure that we do have that restorative space beforehand. Now, the denture will be made in a form of a horseshoe shape, because you're relying on the implant for the support and the bar for the support. And what we need to instruct or ensure that the labial soft tissue undercuts are all blocked off, so we don't engage any of these labial undercuts, because that might interfere with the path of insertion of the denture and prevent full seating, and will lead to more wear of the retentive inserts as well. Okay, so that's the patient with the bars, or an open palate, which is a lot more comfortable for the person. Okay. Now, here you can see that the patient's got a very high smile line. So having a removable implant-supported prosthesis with a flange is important, because you can hide the junction of the prosthesis and the tissues, the mucosa or the tissues of the patient. So you don't want to see that junction, but that has to be planned beforehand to ensure that you've got all the parameters measured before we proceed. I've got nice lip support for the patient. So what we so this study here, that it's a literature review, and it looked at probably one of a very good literature review, because it looked at the 54 studies and assessed a post-loading implant loss rate, and looked at the different positions in the maxilla, the mandible, also whether it's the number of implants, the design of the prosthesis. So it assessed different parameters, and what they found that definitely implant loss rate in the maxilla was significantly higher than the mandible, but they also found that it was significantly higher if we have less than 4 implants. So there was 7.22% of implant loss per 100 implant years, I think they measured. Whereas if you have 4 implants, the loss rate has dropped significantly. So it's a bit more within that 2.3. So definitely 4 implants in the maxilla is a minimum. If you design for relying on the implant for the full support of or retention of the prosthesis. The mandible had a much higher success rate, so there was looked at 1, 2, and 4 implants, and they found that 4 implants has the lowest implant loss rate, whereas 1 implant is a little bit more higher implant loss rate, but significantly higher. So I think looking at this study, they definitely, what we come out with is we need to consider 4 implants as a minimum in the top jaw, possibly 2 or 4 implants in the mandible will have a good success, right? So to recap, in the maxilla, we aim for 4 implants. We may be implant retained, so just a splinted or non-splinted design. Whereas for the mandible, we may consider 2 versus 4 implants, whether we go for splinting or just implant retention, like a solitary independent implants. That's also okay as well, especially if the cases where there's no grafting needed. Now, if we are to, this literature review here have looked at the patient satisfaction pretty much and assessed different aspects. So that's a literature review of 53 studies. So they assessed different parameters, how happy the patients with their prosthetic outcome, and what is their chewing ability, muscle length, muscle thickness as well. And they found that patients who have received an implant overdenture had better biting force, thicker muscle, masseter muscle, and improved chewing efficiency, and overall much more happier with their restorative outcome than patients who had just full denture. Thank you.
Absolutely. So thank you so much, Zoe. Great coverage of this particular treatment modality. I certainly thoroughly enjoyed working with patients using this treatment approach, and certainly significantly improving the patient's quality of life. We all know that from just about every single study that we've read, as soon as you stick some implants in their otherwise edentulous jaw, their maximum clench force increases. So therefore their mastication and probably diet will certainly improve. Now moving on to our final subtopic tonight, which is talking about fixed prosthesis. Johnson, take us through. Quite often there's this question being thrown around. Which is better? Is fixed four-arch bridge necessarily better than removable implant overdenture? And what are the parameters that you might be looking for to provide a fixed prosthesis, and how do you normally carry out that reconstruction?
Great. Thank you, Ben. When we look at fixed or removable, it is important to look from the patient's perspective. Usually, from a literature point of view, like looking at what we call oral health related quality of life studies. So in this study, they divide this into age groups, and they found that the older patients, they like the removable implants overdenture better, whereas younger patients under 55 likes fixed better, whether this is due to the perception that the dentures are for people who's older, and plus in the younger age group they have a little bit more dexterity, whereas in the older age group they used to a partial denture of some sort. So when it comes to the removable implants retained overdenture, they got used to it, and also they don't have as much dexterity, so they find the overdenture much easier to clean. This study splits into 2 groups, and then each first group will have a overdenture first, followed by fixed prosthesis, and the second group is in a reverse order. And surprisingly, they find that 70% of the patients prefer to keep the removable prosthesis over the fixed prosthesis. For the fixed prosthesis, the maintenance requires very meticulous oral hygiene. So a lot of patients spend like 15-20 minutes in the morning and nighttime with different size pixters, and then also with water jet just to try to keep it clean. For assessing whether we have the overdenture or fixed prosthesis, it's important to to assess whether we require the lip support or not. So what we do is, if we decide to have a fixed prosthesis, you can have a wax try-in, remove the anterior flange, or process this into acrylic. And if the teeth position support the lip, then the patient is suitable candidate for a fixed prosthesis. But of course, not all cases, the teeth will be able to provide the lip support. Taking this severe class 3, for example, the patient presented with an immediate full denture, and then was noticed he's not showing much teeth at all and not getting much function out of it. So what we do is we provided him with a removable provisional full denture first to improve the AP relationship. And then we provided him with 4 implants, and then implants retain overdenture. For this patient, like most of our patients on 4 located abutments go for non-extended range green inserts, right? But this patient, he used it like fixed prosthesis, so we went for clear, so which is like impossible for me to remove. But he's an islander, so his fingers are very strong. So he used it like a fixed prosthesis. That's when I know, well, the satisfaction of removal overdenture can be very high. But of course, you know, it just initially I was replacing every month, and he learned, you know, to chew not so much hard food. Then, you know, that's when we changed to every 6 months on clear inserts. For the fixed prosthesis, it's much more difficult to clean than a removable option. There's always the option of a high water design that is much easier to clean. For one of the important assessment is how good is their oral hygiene at the presentation. If they have excellent oral hygiene, then they are a good candidate. But if they have poor oral hygiene, I mean, most of the patients can be improved to reasonable, but rarely can they be improved to excellent oral hygiene. The second factor to take into consideration is, you know, once they have fixed prosthesis, they have a much higher load. So one study looks at, you know, people eating chocolate balls with their natural teeth. They can cut precisely in half, whereas patients with implants, they can crush the chocolate ball, and this is where the implant complication is usually much higher in terms of mechanical complications. It's also much higher expectation in terms of initial cost, but also the maintenance cost as well. With the overdenture, you know, if they accidentally drop it, it's usually, you know, they can take it to the prosthetist and then it's a same-day repair. But for the for your porcelain or fixed prosthesis, you know, acrylic on titanium can be a same-day repair by removing in the morning, sending to a technician, and then come back in the afternoon. But any porcelain is a minimum of a week, so it's important for the patient to understand if they go for the fixed prosthesis porcelain option. You know, if they chip in, you know, the repair process is a week. The best way to prevent it is to wearing a occlusal splint at night time. And then we will have Dr. Bentley talk about us how many implants we need.
So in summary, I guess, Johnson, going back to the original question, which is better, my understanding is that it's based on quite a few factors. Obviously, the patient's choice is extremely important, particularly that study where the patient experienced both fixed and removable. And the kicker was, well, at the end, you can only get to keep one set to take it home. Yep. Which would you like? Yes. The vast majority of the patient went, I want the removable, thank you very much. And that was very, very surprising. And we're seeing, again, a similar trend in these sort of studies, particularly with the patient in the older age group, that they may have a tendency towards removable prosthesis, probably because of its, as you said, easier to clean, easier to maintain, good lip support, ease of use, etc., etc. So it's very, very interesting. But of course, not all cases are indicated for removable prosthesis. Now, if we were to look at fixed prosthesis, how many implants do we need? Because there's a large variation of options out there. The Nobel Biocare Novum system, you only need 3 implants in the mandible to support a full arch prosthesis. The all-on-4 option, as we all know, only needs 4 implants. For patients perhaps that brux a bit more, you want to replace a bit more teeth, maybe 6 implants is a very common choice. But sometimes you want to have segmented approach, or maybe even going for the severe bruxes, maybe 8 implants are justifiable. And then you're starting to see a whole smorgasbord of all different things when you start doing Googling, right? This particular case here, there's 10 implants, but if you calculate the two, that's one in the sinus, one that's buried, is 12. This one needed 11, and this one's 12. And there's probably even more. So really, how many implants do we need to support a fixed full arch bridge? Now, before we go straight to maybe some sort of scientific articles, we have to think, I think, a little bit more rationally, which is how many teeth are we really replacing here? Does every single case or patient needs a 7-to-7 rehabilitation? Probably not. Kaiser, that first proposed or published the idea of the shorter dental arch, they studied this cohort that suggested that 5-to-5 occlusion, most patients still had a reasonable satisfaction in terms of aesthetics and function. And as soon as you have this reduction of 5-to-5 or 10 occlusal units, the patient had a sudden drop in dissatisfaction. So maybe 5-to-5 is sufficient in some patients, whereas in others, often a 6-to-6 rehabilitation is more than enough. As Agnes said early on, sometimes the 7 started to give you other problems, including whether it's function or sometimes whether it's hygiene. In many patients who are bruxers, they simply can't brush their teeth all the way down the back before they start gagging. So maybe more teeth are not necessary. This is one of my patients, Bob. Bob has had this 3-to-3 bridge opposing a maxillary full denture for many years. And Bob, to my surprise, is very happy with what he has. And I'm surprised that it's not lifting or unseating his maxillary denture. So when these lower teeth finally gave, Bob just wanted me to give him a very short dental bridge. And he said, look, just give me another 6 teeth and I'll be happy. And I had to twist his arm a little bit to put in another extra implant or two, because I thought in my mind, a 4-to-4, well, it'll give you a little bit more posterior support. Surely that's going to seat the denture better. I was pretty proud of myself when I finished with this. And when I asked Bob was, feels about the same. So, in Bob's case, probably 3-to-3 is enough for him. And there was no justification to give him any more teeth than necessary. So that's the first thing, I think, is how many teeth are we replacing? The second thing we have to think about is, in this bridge that you're doing, will there be a cantilever? Because very often we know that in the terminal case, you're going to have some sort of bone resorption, whether it's a pneumatized sinus or whether the inferior alveolar nerve comes into play. So in this case here, well, if you're not going to do a lot of complicated grafting, well, that's the only space you have, is to place those implants in the premaxilla. So perhaps that could only give you a 4-to-4 sort of range, and that may give you may need a very long cantilever if you were to replace a lot of posterior missing teeth. And we know that if you were to just simply angulate the most distal implant slightly, that may help you to reduce your cantilever. So can you reduce that cantilever will be another question. And if, is grafting in the sinus a possibility, a feasibility, or financial affordability for this patient? And if so, well, now maybe you can place even more number of implants to where the most distal unit is. So therefore you completely eliminated the cantilever. In simple 2D vector diagrams, we know that the longer the cantilever, well, the lot more force that you're going to put into your fulcrum, which is the most distal implant. In a lot of studies, they've also shown that just by simply having 1 unit of distal cantilever significantly increases the stress of the most distal implant and the most distal prosthesis. And in this very complicated study, what they did is that it's essentially almost like an all-on-4 sort of lab study, where the very last implant, they placed them at 0, which is straight, 15, 30, 45 degree angulations, and therefore they can reduce the distal cantilever. It's a very complicated study, but simplistically speaking, what they found is that when you reduce your cantilever, you significantly reduce that loading force. No surprise there. And when you are angulating your most distal implant and thereby reducing your cantilever, you even further can reduce your your unfavorable forces. So that's why in a lot of the clinical cases, what we see here in the case that's referred to us, that this patient in the quadrant 3 bridge, it simply had a catastrophic fracture of the prosthesis. Now, of course, there's a number of reasons why this has happened, including perhaps the vertical dimension control, maybe the material used, and parafunction. But ultimately, that's a 2-unit distal cantilever. There's a lot of forces there as well. So always consider to avoid the cantilever if possible. And now again, that may mean reducing the number of teeth you're replacing. That may mean that you're grafting a bit more so you can place the implant more distally, or you may mean that you're angulating the implants. So try to avoid the cantilever at all cost. That's purely from a mechanical standpoint. And if you really can't eliminate that cantilever for whatever reason, at least maybe just have 1 unit of cantilever as opposed to say 2 or 3, which is really could be danger territory. Partly it depends on what you're opposing to. If you're opposing a full denture, maybe that risk is not as high. And there's one final factor to consider. How many implants do we need is that are you going to utilize all of your implants or not in this fixed rehab? It's what otherwise known as cross-arch stabilization. Because if you're not utilizing this and you're only making, say, short segmental bridges, well, you may need a lot more implants than just the 4 or the 6. So very typically in or in my trend of thought, I would spread the implants as evenly as possible in this arch, whether it's the anterior or the posterior implants. I will evenly space them out as much as possible, and typically I place them as axially as I can, not because that angulated implants don't work. Well, as soon as you start to angulate your implants, you're reducing the compressive loading onto the implants, you increase the shear force, and so therefore, by having them axial, you're loading them as compressively as possible, and thereby the fixed prosthesis also, there's no cantilever needed as well. And if we were to look at this question purely from an academic perspective, once again, the Kern systematic literature review is probably one of the best ones out there. And what they looked at is the 5-year survival rate. Everything's looking pretty good. For the maxillary arch, similar to what Zoe was saying before, our failure rate is slightly higher compared to the mandible. Once again, because of the softer bone, no surprise there. And there are some evidence to suggest that 4 implants or more in the mandibular arch is very, very favorable, especially if it's 6 or more, 5 or 6, whereas in the maxilla, there's some studies that suggest that 6 or more implants are more favorable, purely from a number of implant loss point of view. Some of the 0-on-4 studies, of course, are also available, but we can see that the survival rate is approximately 95-ish% at the implant level. So we can definitely see there's a reduction in survival rate there. And the other thing is that if you are interested in 0-on-4, you have to ask yourself, 0-on-4 what? Because just because you got 4 implants there, it doesn't mean that all behave the same. Are they 4 relatively wide diameter and long implants? Or are they 4 zygomatic implants, like Zoe touched upon? Or is it 4 tiny little mini things? Because they're all, in theory, 0-on-4, but the mechanics, the spread, the cantilever is vastly different from one to another, and therefore, of course, the longevity as well. So to sum up in this question, how many implants do we need for a fixed full arch prosthesis? There's quite a few different factors you got to go through. How many teeth we're replacing? How good is the bone, as in therefore, how big is the implant that you can put in? Is it 4 or 6 pretty big implants, or are they tiny little things? Would you have to have a cantilever? Can you stabilize all the implants in one prosthesis? How severe is the parafunction? Maybe what the prosthesis is opposing, what the patient needs for, and ultimately from a literature standpoint, somewhere between, while 4 implants can certainly work in some cases, but 5 to 6 implants may reduce your long-term implant loss. So let's continue with Johnson, just to explore a few factors of when we're deciding a fixed prosthesis, what do we really need, what we're looking for, and how do we do these things?
Great. Thank you, Ben. So one of the things to look out for would be what we call the transition line, which means it's the junction between the soft tissue and the interior surface of your full arch dental prosthesis. So this is important in patient with this is the line, and this is important for patient especially with a high smile line. So as Dr. Thao and Dr. Zoe has touched before, so if this line is visible when the patient smiles, so it's important when planning the surgery to have bone reduction or osteoplasty to ensure this transition line is going to be above the smile line. Because if you don't, when people smile, that junction will be visible and is considered unaesthetic. So always have to ensure this line is hiding in patient's smile. The second consideration will be how much space or the minimum restorative space do we need. For a porcelain fused to zirconia or metal, we need minimum of 12 millimeters. And if we have zirconia or acrylic on titanium framework, we need 3 millimeter more, so a minimum of 15 millimeters. Basically, we need more space for the framework. So when you design from beginning, either you need to increase the occlusal vertical dimension if it allows, or if not, osteoplasty to achieve your minimum restorative space. Taking this case for example, the patient was referred for initially dental implants in quadrant 1. After extraction, while the sockets are healing, she fractured a very long porcelain fused to zirconia bridge in quadrant 2. So if you look at the RPG, what we can see is, although we can still try the segmental approach in quadrant 1 and quadrant 2, but in the anterior segment, underneath the bridge, she doesn't really have much furrow on the remaining teeth, and there's a little bit of a periapical infection. So what she has decided for a full arch clearance. Because she's a little bit of a gagger, so she cleans very well as well. So she's decided to go for the full arch fixed prosthesis. She's provided us with her wedding photos that was taken 10 years ago. It's important, to assess, like Dr. Agnes was saying, on the psychology of the patient, whether this patient is suitable. I once had a patient who was like 85 years old, and then she provided me her wedding photo. She said she wants to look exactly like that, like when she was 20. So I feel, based on a few other assessments, that she wasn't suitable for me to treat that. In other words, I would never satisfy her expectations. So we always try to provide her a provisional denture that she is happy with. This is towards the end of the provisional phase, where she's chipped tooth 1, 2 because she dropped it, not because she's a severe bruxer. Significant sinus lift was performed in this case to ensure we get a good even AP spread without the need for the cantilever. We do a splinted impression, so we find the thickest wire available. So we'll use a light cure resin. We cure the buccal first, and then we cure the palatal wire, and then we split in between interproximally to ensure we minimize the shrinkage. You can do a light body to putty PBS impression, or you can do a light body to heavy body PBS impression. For the bite restriction, we made a copy, or we used a surgical guide, or based on the duplicate denture. We use the taller healing abutments, and then we do a bite restriction. For the taller healing abutments, it's important to pick the same height. So if they 5mm, just use the 5mm or across the board. Initially, I gave my technician a mixture of 7 and 5mm, but the technician returns that, hang on, your butt restriction doesn't really fit. But basically, although you can write your lab description to say where the healing abutment goes at which side, but they're usually quite busy, so they don't put it in the right place, so they send it back. I put them in the right place, and then what I learned is it's better just to give them all the same height, so they're less likely to send you back. For the trying, we do a PMMA trying, and this can be PMMA on 2 of your non-engaging universal base or your temporary cylinders. You can pick 2 or 3. My technician prefers to have the universal base, which allows angle correction as well, and because he have less need for trimming, he doesn't need to trim. And we try in, the patient was saying, people know me as very teethy, means showing a lot of teeth. So the current PMMA just doesn't show enough teeth. So what I did is I slap on some composite on the central first, ensure she's happy, and I do the lateral, and then I do the canine. And then I do have an aesthetic articulator, so that means I just determine the incisor length, and then my technician can just sort out the leveling in the laboratory phase. The next step we can either do another try-in, or I was quite comfortable with the length, and we proceeded with the final prosthesis in porcelain fused to zirconia. This is suitable for a patient with mild, maybe mild to moderate dental parafunction. For a patient with more severe dental parafunction, it's better to design with a titanium framework. And most patients, most ladies go through the rehab, prefer to have their teeth a little bit lighter. She chose the shade of A1, so which is, men chooses, A2, A2. A2, A3, but ladies choose A1, which is significantly whiter than her mandibular arch. But when she smiles, she mainly shows her maxillary arch. And because she's a Geiger, she cleans well. She was quite happy with the prosthesis.
Great case.
Yeah.
I hope she's happy.
Yeah, she's happy.
It's been a very long session. Thank you so much for joining us again, ladies and gentlemen. We'll wrap up very, very quickly. Going around the table, just some, if it's one sentence summary that you want our audience to take away home tonight, what might that be? I'll start off with Thao.
I think making sure that your patients are safe, and it's based on the medical management of the patient, as well as thinking about the long-term outcomes for the patient and planning ahead with all the appropriate professionals. Either if I'm doing surgery, I would be planning with the prosthodontist as well to have the appropriate outcome for the patient.
Great. It certainly is the team approach. Agnes?
I think being able to have a very clear, informative maintenance schedule, as well as
Supportive prosthodontic therapy. I really like that.
Yeah, but as well as I think it is very much a reality of having more complex dental treatment in the community in our 45 to 65 cohort that I do observe. I just so wish that the innovation or the type of prosthetic rehabilitation can explore to a level of maturity where the utility and the access can be more universal. I mean, questions flowing in asking about magnets, but we now see locators are very serviceable. A lot of dental community understands and able to surface it, and it is becoming a preference of choice, because even if our patient can no longer access specialist maintenance, or they are in a facility, it's an easy modality for anyone to assist. If only somehow our fixed prosthesis can have a contingency plan to follow into the future, where it has the capability of converting predictably or readily into a removable option. I think that would be personally very exciting to see.
For sure, for sure. Now, Zoe?
And important to remember, never give up on teeth, so try to prolong those as long as possible. Patients are living longer.
For sure.
And there's a lot more complications and issue will arise as they progress through life, and dental treatment that we do today may not last in about 20, 30 years. So definitely keep prolonging what they have, and then once that fails, then we can add more options. So just keep the options open for the patient.
Definitely. And how about you, Johnson?
I think it's identify the risk factors and then
Yes.
get the patient to own their risk factors, right?
Yes.
If people who can crack their own teeth, they're going to crack whatever we do unless they take ownership and do steps to prevent that from happening.
Absolutely.
Yeah.
Ultimately, the terminal dentition is the patient got there from a multitude of reasons, and if we, I think, jump too quickly into that final treatment, well, you may start to unpack a lot of unknowns. So I guess my take-home message will be just take it slow, go one step at a time. If the patient has a terminal dentition, there's nothing wrong providing with the patient with a full denture first. See how you go before you're committing to the next step, because you just never know what you may find as you embark on that journey. So once again, I want to thank the panel for joining me. Thank you guys for put a lot of time and effort into this. I really appreciate your presence. And for our audience tonight, thank you so much for joining us. Thank you for your continued support of our team. We deeply appreciate it. And yes, you will be getting a 3-hour CPD for tonight. And again, a final reminder, the certificates don't automatically come out to you, so please do scroll down to the bottom to enter your email address if you want a CPD certificate. And wishing you guys all the very best towards the end of the year. We are towards to that crazy end of the year period. It might be slightly early to say Merry Christmas, but it is certainly around the corner. So wishing you guys all the very best, and also for the next year as well. On behalf of the team, thank you, and good night.